I go over how the heart works, and sometimes I don't. Depends on if we have time. Did I with you guys or?
I don't remember.
We are a mixed cohort, so I remember
I
it.
remember, and I still have the notes, so I do remember.
Okay.
Linda did.
Well, I think we should go over it again, though, just as a refresher, and then we'll get into the PowerPoints, okay?
Okay.
All right.
Take it off.
So there's our heart. Four chambers, right? Remember that? Atriums, ventricles. I know that's a lot of review. We all got that. So let's start. It does three things. Mechanically squeezes. It's got electrical activity that causes all that to happen, and then it's got hydraulic function as it goes through it, right? The blood. So those three things are what it does, and it does it real well for a long, long time. So first, let's look at the electrical activity of it. So where does that initiate in the heart? Where does that start? You remember?
SA node.
SA node, so that's like right here, right? And that's the SA node. How fast does it normally go?
100 no, it's 60 to 100.
60 to 100, okay.
Sorry.
So, here's our SA node. Let's say this person's not in the better shape you're in, the lower your heart rate. We all know that, right? So let's say this is just an average person and they're about 92 beats a minute. Gets generated from the SA node. What happens to it then?
It goes to the AV node.
All right. Travels through the atrium, right? And it gets down here to the AV node. And then it goes through the AV node, then where does it go?
Bundle of his.
Okay? And through all the Purkinje fibers in a bundle of his, right?
Yeah.
So why does it do that? Comes around like that, right? Very small area up here in the atrium. The electricity can just wash over the atrium, and that's fine. It does cross over to the other atrium. You do know both atriums fire at the same time, right? Both ventricles fire at the same time. They're not separate events. So we're listening to the heart, we hear lub-dub, right? Lub-dub. That's the atrium's ventricles. Atrium's ventricles. We don't hear lub-lub-dub-dub. Or we shouldn't. Sometimes we do, but we shouldn't. We hear lub-dub because they go at the same time, atrium's ventricles. So it kind of washes over there, gets into the AV node, it makes its way through. The body spreads it all out because these ventricles then are so much bigger than the atriums. So we don't want the electricity to just wash over the ventricles. Even as fast as it is, that would be too slow. It would be too wide of a complex. So it wants the electricity to spread out from all of these points along the Purkinjes, and so that the ventricles collapse all at once, or fire all at one time. Can you picture that in your head? So under normal circumstances, that's what we've got. All right. So what if I'm standing up here in front of you today, and I have a heart attack, and it damages the tissue here at my SA node that knocks it out? What happens?
You're going to go to your AV.
I'm going to just drop dead? No? Somebody said AV node takes over?
Yeah. I
Yeah?
don't.
Okay.
I'm assuming.
Nothing happens before that?
Would your do ventricle or atrium override? Or?
How fast do AV nodes run?
Is it higher or lower than the SA node?
It's lower.
So
let's do
then
like 50.
40 to 60, right?
40 to 60.
So let's say it's like 58 for the AV node. the fastest it would go. So if I wipe out my SA node, then my heart rate drops automatically to 58 then? Doesn't sound right, does it?
No.
Because it isn't. So your SA node is what's known as a foci. And those are little specialized areas of cells that are able to generate electricity. And the SA node can do that. But up here in the atriums, we've got a bunch of other foci. And so, they're also able to generate electricity
So then the
as we go
atrium is-
along. So if we wipe out our SA node, our next fastest foci in our atrium will take over. So maybe that one's going at 90. Well, how come this one's not firing at 92 and that one's firing at 90 all the time? This is where we get overdrive suppression. Okay, we have automaticity, which is the ability to generate the electricity, but overdrive suppression happens here. So, this one's trying to build up an electrical charge. It's gonna fire at 90 a minute. It's going to build it up, but this one's faster, it's 92 a minute, right? So when it fires, it takes that one's electrical charge and washes it out with it. And so then it starts to build up again, but gets washed out from that one. The faster one is always overdriving, suppressing it. So it never gets to the point where it reaches its peak and fires, because the other one is faster. Follow me? But if this one's wiped out,
Then it goes to 90.
then this one will reach its peak and fire. And then the other guys behind it, down the line, the other ones, as they're building up, what's happening?
They're getting
They're
more
doing
exhaustion.
Their electrical charge is getting drugged out of them and taken away, right? They never get to their full potential because they're slower than whoever the fastest guy is at the moment. And that's a backup system for us. Okay?
So you're saying that like for example, 92 is taken out what I wiped out, and it's 90 to reach its peak. It takes out from the 88s, 85s, and 83s.
Yeah, so this one normally is, the SA node's normally the king.
Right.
It's the fastest one though, and that's why it's the king. So it reaches its potential and it fires.
Okay.
But when it fires, it's taking all these other with it.
Okay.
They can't get to their potential because this one's faster.
Okay.
So it'll grab their electricity. But if we had a heart attack and we wiped out that SA node, this one's now the fastest. And he'll wipe out all the ones behind him as we go along.
Yep.
Okay? So that's overdrive suppression. So whoever is the fastest suppresses all the slower ones from it. The AV node, what if we had such a massive heart attack or some kind of a block where that electricity doesn't get from the atriums into the AV node? The AV node then all of a sudden is not overdrive suppressed. Normally it is from the electricity coming down it. So if it doesn't get suppressed, it's going to start firing here at this 58 a minute. All right, from the little foci in there. But guess what's there too? There's a bunch of them inside of the AV node. So depending on where the block is, or if there's some damage, we might have another one, 56, 55, 49, whatever, down the line. But they're all being overdrive suppressed. If there's no blockage or anything there, this SA node, as it's going through, is suppressing everybody, right? Including the AV node.
So the AV node kicks in when SA node doesn't suppress until 58.
Or any of these foci up here aren't suppressing it.
Okay.
So if it's not suppressed, it'll make its potential, its action potential, and then it'll fire.
Okay.
And that's true on any of them. If they're not suppressed, they'll fire. They
Okay.
build up and fire. Okay? What if we had damage here? Right? Well, the ventricle has a bunch of them, right? Normal ventricular rate, any idea? Who said 20 to 40?
All of us.
Everybody did, so you're right. So what if this is 38, and this one's 32, 28, 25, whatever? If nothing's coming down from the AV node and suppressing it, our ventricles will go into these rhythms. Are these good enough to sustain life?
No.
Maybe temporarily, right? But not any kind of quality life. These are escape rhythms then, escape beats are what's happening. So it's our body's last effort to say, oh, I've got to generate the heart. When we get down to the ventricle, then that's the full size down here, right? And it could be whichever one is the fastest, not being suppressed. Again, same idea. So whoever's not getting suppressed is gonna fire. Following me so far?
Yes.
Okay. All right. So there's different parts of the rhythm that the electricity that we see on the rhythm strip because of this. Do you need this part anywhere? Can I use this board? Okay. Everybody's got the idea of overdrive suppression. Okay. So, when we're looking at a rhythm strip or a monitor or anything of that nature, it represents the electrical activity that's going on in this heart. So we've got what looks like this, right? And then it starts over. All right, look familiar? Okay. What's this? Anyone know? P wave, what does that represent?
Atrial depolarization.
All right, so when the atriums depolarize, when they fire, depolarize, we see the P wave on our monitor or on our rhythm strip. Then it travels over, gets into the AV node. We have this little area here in our PR interval. As it's traveling through, it goes down the Purkinjes and it fires to the ventricles. We have this big QRS complex
So QRS is the firing
of the ventricles, right? Small event, atriums are smaller. Big event, right? Ventricles are bigger, so it's a much bigger and electrical type event. Then we have our ST segment and our T wave. What's our T wave?
filling of the SA node.
Okay, so we had here depolarization of the ventricle fire. Anything that depolarizes has to repolarize before it can fire again. This is the repolarization of the ventricle,
Okay, so the T wave.
okay? The T wave represents the repolarization of the ventricle so that it can fire again. We don't see the repolarization of the P wave, of the atriums, for two reasons. Number one, it's really small. And timing wise, because it's really small and the time, when it's repolarizing, it's happening during this depolarization event of the ventricle. So we will never see it on a trace because it's lost in there. It does happen, but it's gone from our view. Follow me so far? All right. Potassium is so important to the heart. So important. And every time we're dealing with the heart, we're dealing with potassium. The reason is this entire electrical network, you know, like if you had wiring in your house, it would be copper wiring going through the house or whatever. In our heart, this whole network is built on potassium. And potassium fires electrically very, very fast. There's one little area that isn't built on potassium, that's right here. One little spot inside of that AV node is built on calcium. Well, that's weird. Why would our bodies do that?
It's a fail system, it's a backup, because it's gonna kick in if it needs to.
Good guess, but it's not correct. Good guess though. Potassium is super fast, like flash, right? Calcium carries electricity just a little bit slower. So what happens is, as we're looking here, this is the portion when it's riding over this calcium, and that gives the heart, where the atrium squeeze, gives the heart time to fill the ventricles with the blood. It just slows it down just enough that we could get filling into the ventricles, because without it, once that electricity was starting to fly, it would just be bang, bang, like, it would be so fast that it wouldn't have any time to fill.
Is that kind of like with the SVT?
Okay, we'll get into dysrhythmias here in just a minute.
So basically calcium helps to fill the heart.
Well, right, so the calcium tends to slow down that electrical signal just enough that we get filling into the ventricles. It gives the time for the blood to get from the atriums into the ventricles before the ventricles fire, and then squeeze it out, either go into the lungs or into the aorta and out to the body. Without that pause, we would be in trouble. We wouldn't get enough filling. And like in SVT, what you're kind of talking about, if it's beating so fast, we don't get filling, and so our cardiac output drops because we're not pushing that blood around. But we'll get into some dysrhythmias. No, don't be sorry. This is a great discussion.
It's all hacking here.
It is.
That's why I'm fanning myself.
I just thought it was because I'm like really large and we're warm all the time.
It's your birthday, you won an award.
Ugh. Here, let's open the door for a while. What do you think?
Sorry.
Okay, so that's why that's there. And what if we were using a calcium channel blocker? What happens?
Well, then
It
that
slows
would
it down even more, right?
It's
like a slow.
Yeah, right at that spot.
So is that the whole purpose of it?
Well, yeah, there's in any action potential in the body, any action potential in a muscle or whatever, there's calcium interplay too. And we consider that calcium channel as well. But this is a big one, okay? 99% of our calcium in our body, where is it?
Bone.
In our bones. We got that 1% floating around to support this kind of thing, is really what we're after, plus blood clotting that calcium is involved in, right? So that slows it out just enough for us to go there. What's this area here after the T wave and before the P wave?
Repolarization buildup, the preload.
Just
Almost.
extra.
It's absolutely nothing.
Oh.
This is dead time for the heart. Okay? But we love this segment here. As nurses, we love it because it does one thing for us. It gives us a baseline to where our trace is. So wherever this is our baseline. And so if we're looking at our monitor and our EKG, and we see what this thing is
I saw that from you.
like this.
ST segment elevation.
Yeah. So that's QRS segment. Our ST segment is higher than our baseline. We've got ST cell section elevation. So when we say, hey, we think the patient's having an ST elevated myocardial infarction, we weren't just guessing, right? We're looking at this compared to here.
Sam.
Mystery solved. Now this is getting too easy, right?
No.
Yes.
It is.
Good score.
It's really an easy thing.
For you?
What if one of these guys is firing out of order. Either, remember we said overdrive suppression. Sometimes overdrive suppression doesn't work. If we've got a disease process going on, or we're chemically imbalanced, and we're looking at our CMP, our complete metabolic panel, and our values are all weird, we can have where don't want to be overdrive suppressed. They're mad, and more than one can fire because of it. So nothing can get in to suppress it, and it will fire by itself. The ventricles, as a matter of fact, are very susceptible to a low oxygen environment. If they're oxygen deprived, those foci down in the ventricles will get angry and start firing on their own. But this pathway here, if we're looking at this, a normal trace, everything's going along the normal electrical pathway. We know that. We've got a nice tight QRS complex because it's falling down through here the way that it should. If one of these guys that's not on the normal pathway, like one of these ventricular foci fire on its own, on our EKG, we might see something like that. Okay? And you're going to recognize that as being a PVC, right? Premature ventricular contraction. So one of these guys decided to go rogue. He's mad about something, low oxygen, whatever. Not enough potassium. Too much calcium. Magnesium's weird. Whatever. It's mad. So he fired. But because it didn't follow the normal pathway, when he fired, the electricity kind of fanned out over the ventricles. And so the ventricles, instead of firing both together real sharply, just went kind of, and we got this big honking wide complex because of it. You get it?
So that's a ventricular foci misfire.
Yeah, it's a premature ventricular contraction for whatever reason. Now, if we're starting to see these, if we get more than a run of a few of these together, then we're saying VTAC, and you and I as nurses have got to go, man, I got to figure out why this is happening. Because I got to stop it because it's going to get worse. All right? Probably to the point where we're doing CPR and we don't want to be there. Right? We want to sit by our computers. We want to have our Starbucks, eat a donut, whatever, while we're doing charting. We don't want to be in there doing CPR and crash carts and all that stuff if we can avoid it.
We have to do that this week.
So that's the deal there. Follow me so far?
Yep.
Want to look at some dysrhythmias in that, or?
Yes, I do.
Okay, let's do that. So armed with that knowledge of what we just went over, armed with that, when we're looking at dysrhythmias, think back to what we were just talking about, and how can this dysrhythmia be explained by what we just went over? And all of a sudden, it's gonna all start to, the little lights will start coming on. All right?
Hope so.
I gotta hook this thing up. I think Steve thought this was a joke.
No, he did that because it was making these very loud obnoxious coming.
So it's like it can barely reach from one side of it to the other. So you're probably noticing right away, or you will as soon as this comes on.
No, a little bit. I'm gonna start part two.
If you're really astute, you're gonna see that we're starting with the second set of slides instead of the first.
Sorry.
Sprouting flesh.
Okay, so dysrhythmias and into shock. Here's just another representative of what I just told you about the rhythm. So you got that on your PowerPoint sheets that you can use. Number 1's P wave, right? 2 is a PR interval. And later on, we're going to be talking about should be 20, 0.20 or less. Otherwise, we're getting into blocks. So then we start to measure things as we're going along, right? But everything here is just as you and I just talked about. So if we're going to look at an EKG and see problems there, they can only fall into certain categories. Rate problems. Normally, normal adult human, 60 to 100, right? So if it's above 100, what do we got? Tachycardia. If it's below 60, what do we got? Bradycardia. Right, with some exceptions. If somebody's really athletic, a lot of people that run marathons or do that kind of thing, they're down in the 50s or the 40s with no symptomology, but they're kind of not the normal population that you're going to see in the hospital, right? Because they're too fit. So rate problems, above or below that normal area. Rhythm problems, not in normal sinus rhythm. So we've been talking about normal sinus rhythm as we went along there, right? So if it's not normal sinus rhythm, then it's a rhythm problem. There could be other conduction problems like heart blocks, and those basically are the electrical currents are having trouble getting through. Either they're slowed, delayed, or completely blocked. There are 4 heart blocks. 4. Okay? So if there's 4, type 1,
Type 2,
type 2, and type 3. That's one weird like that, right? So we've got 2 type 2s, and we'll get to them in a minute too. And the origin of the electrical activity. The origin should be as we displayed, SA node through going through the whole thing. Even if it's a foci up in the atrium, okay, it is following the normal conduction pathway, that's good. If it's doing anything else, we can tell on our strip that we've got origin problems on our electrical activity, okay? Now we talked about rate problems, tachycardia, bradycardia, one we didn't mention, the ultimate bradycardia, asystole, right? A rate of 0. Flat line. If we're on TV, we would shock them, but we're not on TV.
We just get up
So, right. Why do we shock a patient?
because they have a rhythm that's shocking.
Right. Well, what does the shock do?
It restarts the SVAP.
Okay, in a nutshell, when we shock a patient's heart, it stops it. Okay, it stops the heart. And then we're hoping that these foci will go, oh, okay, I'll build up and boom. And restart in the normal fashion. So when we shock a heart, we shock it to stop it. If we're in asystole, it's already stopped, right? So it doesn't, we wouldn't shock it. It's not like jumper cables on your car. It's not gonna do anything. So when you see that on TV, just chuckle to yourself. It's nonsense.
So then
Okay.
what do you do for asystole?
CPR to initially, right? But then, yes, exactly. Then we're gonna go into drugs that will kick it up. Epinephrines, lidocaines, atropines, things like that to try to get it going.
Okay.
Yeah. So that's the 3 there for rate problems. How do we find rates? We can do all kinds of crazy things with math, and we can count these little blocks, and we can get out calculators, and we can do all that kind of stuff. So you want to do that? I don't either. Okay? I don't either. If you're running a rhythm strip off of a machine, or you're in a hospital, you run a rhythm strip. Or if you look on a monitor too, you see these big marks? Those get marked every 3 seconds. Okay, every 3 seconds. So if you put 2 of them together, what do you got?
6 seconds.
6 seconds. How many seconds in a minute? 60, so it becomes a real easy math problem because now we're dealing with base 10. So if I'm looking at this is a 6-second strip, and I count my QRS as 1, 2, 3, 4 times 10. What's my rate? Roughly 40. Could it be 45? Sure it could. We're just doing a rough estimate by looking at these, right? So there's this big gap here and a big gap here. Maybe we're even knocking on 50. Maybe. But we know for sure we've got 4 because we counted them out. How about the top one? 130, 100. Very often if you got one on each edge like that, you'll drop one off of your counting just to compensate for it. So 120-ish. So the top one is representing what? Tachycardia. The middle one's representing bradycardia, and this bottom one?
Asystole.
Bad news, right? Asystole there.
Check the monitor first, or check the patient first.
Yeah,
Oh,
check the
absolutely.
patient first. I've seen that. They're just talking.
Now, is this pretty sinus? Even though it's fast?
Yeah.
It really is, right? We're seeing P waves and QRSs that correspond with the P waves and T waves after it and all of that stuff. So it's like, it's pretty sinus, although it's fast. So this would be sinus tachycardia up there on the top. And this one down here, sinus bradycardia, we're still seeing a P wave, right? Anytime we start to read a strip, the first thing we look at, of course, are the P waves. Always the first thing.
So you start, like, let's say the top one, you start at the first.
Well, if we're going to analyze it, I want to look at these P waves. Are these P waves equal distance apart? Are they shaped the same? Why would I care what they're shaped like?
Because that indicates different deficits and all that, right?
Well, let's go back to what we were talking about
Atrial
on our drawing that we made, right?
P-waves is depolarized SA node.
Okay, so let's think back to our drawing. First, a brief synopsis on how the electrical activity gets to the paper. All right, we put on those leads, right? 3 leads, 4 leads, 5 leads, 12 leads. It depends what we're doing, but we're putting leads on. If electricity is coming towards a lead, it goes up. It's a positive deflection. If electricity is going away from a lead, it's a negative deflection on the paper. Okay, so it would be going down. So no matter where I put these leads, if everything's coming off of the SA node, that P wave is going to be coming at, because the SA node's not moving, and the leads aren't moving, right? So the electricity is coming at those leads from a specific angle. If I move a lead, that little trace will change slightly. But wherever it's stuck then, we'll see that coming. So if I'm seeing different shapes of P waves, I'm seeing electricity coming from different foci, not just one. Follow me?
Yeah, that makes
And this is like magic, isn't it?
sense. I swear.
How this works. Yeah. Same way here. We're seeing the P wave. Looks pretty much the same all the way through, doesn't it? So it's coming from one spot. Can we definitively say it's the SA node? No, but we know it's coming from one foci in the atrium, one of them. So we can figure that out just by looking at this. All right. Coming towards the lead, going away from the lead. Same way to T waves when it's repolarizing. Okay, which way is the electricity traveling? Sometimes we flip a T after we have a heart attack because it's got to go around scar tissue. So this can tell us a lot, can't it? Atrial dysrhythmias. So we can have different dysrhythmias. Dysrhythmia just meaning that it's not normal, right? It's an abnormal rhythm, dysrhythmia. So atrial dysrhythmias happen, guess where? In the atriums. Okay? Not saying they're not important, because they are. But do you think Which one's more important, atrial dysrhythmias or ventricular dysrhythmias? Ventricular would be worse, right? Okay, but we don't want to ignore the atrial dysrhythmias because they're kind of important too. We get that kick. Remember, we're going to have that pause in that calcium so that we get that filling pressure. If our atriums aren't working right, we don't get that atrial kick is what we call it, where it's kicking that blood down into the ventricles and preloading them. So we can lose as much as 30% of our cardiac output if the atriums aren't behaving right. So it's still important because our cardiac output, we need that to circulate the blood, oxygenate all the tissues, get everything where it's supposed to go. Atrial fibrillation, we have a total disorganization of the atrial electrical activity, resulting in a loss of effective atrial contraction or that atrial kick that we're talking about. This is the #1 dysrhythmia that we see on people is AFib. They make commercials about it, right? Take this drug, take that drug. Yeah. Can be paroxysmal, which means begins and ends spontaneously. We see a lot of it after heart surgery. Patients will go into atrial fibrillation for a while, and then we'll pull them out. We'll use like amiodarone or whatever, pull them back out of it, and they can really resolve itself. There are other long-term ones, which we would say persistent, which is lasting more than 7 days. Could be because of a valve problem that's irritating the atriums or whatever. There's a lot of different reasons for it. It is the most common. It is clinically significant with respect to morbidity and mortality because we lose part of that cardiac output. And that's just so important to us. We have to have it. So if we have atrial fibrillation, it's just going all over the place. What do you suppose is going on with those foci?
They're misfiring.
They're misfiring. How many of them? Yeah, or more than one, right? Usually several are all doing their thing. So they're mad, they're not responding to overdrive suppression, and they're just all over the place. And when we get to the rhythm strip, you'll see that on the rhythm strip. Atrial flutter is like its evil cousin to atrial fib. Here it's an atrial tachydysrhythmia. It has recurrent, irregular, sawtooth like P waves. Usually we see 3 or 4 of them between each QRS complex. These sawtooth, and we'll see it on coming up. But they're all alike. So what does that tell us?
They're the same area.
We've got one foci that's angry, and it's going tacky on us.
So the atrial fib is multiple and the atrial flutter is only one.
Usually only one, right? And it's going tacky on us. And we can see that when we're looking at our rhythm strips. And so you and I, as nurses, will look up at the monitor and go, oh, we're in A flutter. What do we want to do about it? And we'll get to there in just a little bit, okay? But the sawtooth is the gold standard on this atrial flutter, and you're going to see in a minute the difference. So here's why is this a problem? Loss of effective atrial contraction, so we're not getting that atrial kick, we're not preloading those ventricles with that blood. We still get some going down because of gravity and the force behind the hydraulic fluid, right, and all of that. But we lose about 30% of our cardiac output because of it. This can come and go, or it can be constant. Again, most common dysrhythmia. We'll have an irregular heart rate because of it. And palpitations. Sometimes the patients will report it feels like there's something fluttering in my chest. So they'll tell you that. Yeah, I feel this fluttering, this weird event going on inside my chest. Atrial rates on here can be 350 to 600 contractions a minute. This does nothing for our cardiac output. Nothing can happen when it's going that fast. It can't contribute. It's very chaotic. We have all these different F waves, but you'll see where they're just all over the place. We try to get, when we're in AFib, we try to get it under control with drugs. That's our first goal, is to immediately get it under control. Uncontrolled is greater than 100, and this is for our QRS complexes, because they're going to react to electricity coming down the pike. And so if they're responding by being tachycardia greater than 100, we consider it uncontrolled AFib. If we get that under 100, less than 100, it's under control. So at least we've got that. And we can do this with various drugs and that. We'll get to all of that. It can alternate with a flutter, although that's kind of rare for it to do that. But if you see it, don't be, like shocked. Some of the diseases that cause it: coronary artery disease, okay, cardiomyopathies, so sick heart is basically. Hypertensive heart disease, heart failure. We used to call it CHF, congestive heart failure. I'm told we can't call it that anymore. We're gonna call it heart failure now. Somebody changed the rules.
When did that change?
A couple years ago, I think.
I was gonna say, because my hospital still uses CHF.
Yeah, and nurses, are pretty,
Set in their ways.
Yeah.
we're pretty habit driven on a lot of things. So nurses are gonna say, yeah, CHF. Pericarditis, what's that?
Pericardial sac.
Inflammation, right? Itis, inflammation, the sac that surrounds the heart, we've got that fluid in there. That's gonna be important later on too. And cardiac surgery, we often get atrial fib, like I was saying before, because we've irritated everything. Because we're in there manipulating the heart around and doing things with vessels, and, just basically handling it all, and it doesn't like that. Here's a typical trace. These are the lead numbers. So if we're doing it like a 12 lead trace, we would have different lead numbers. And the way that the events show up on the lead, again, depends where we put that lead. So if it's on a 12 lead and we're running them all along the side, they're getting a view from a different angle. And that's why it all lines up, because it's all the same heart rhythm, but we're looking at it from a different place in space. Follow me on that? Usually we like lead 2 for monitors and that. As nurses, we love lead 2. Okay, it's kind of an anterior view on the heart. Here's your P waves in that. What's going on there? It's just,
You're having the AFib,
It's AFib.
Or the patient's movers.
it's AFib, so they're shooting from a different angles or different places,
right, so, but if we're just looking at this one lead, we've got different foci that are all doing their own thing in there during this AFib, and that's why we're seeing different shapes and different rates on them. And as the ventricles repolarize and things get through, then the ventricles will fire. So sometimes they fire quicker than other times. We wind up in AFib, because of all this electrical activity coming down, with an irregular rhythm. See that? There's nothing regular about this. That's classic AFib. Classic. So all these different foci weirding out on us, getting through at different times. This is controlled because it's below 100. So we've controlled this probably with some kind of drug, amiodarone or lidocaine or something. But it's classic AFib. Significance, again, lose that kick. Here's the biggie and why all the TV commercials. Because of that, we could have blood that doesn't get pushed through, and it could become what we call stasis. It's staying in a certain area, it can clot. And then when it does break through, we throw it through, it goes up the carotids, causes a stroke. That clot, right, gets jammed up in there. And so that's why we're really worried about AFib and strokes. And so we want to anticoagulate them so that we don't get these clots. So usually we use Coumadin. There's a lot of Eliquis, there's a lot of new drugs out there that we can use. Drawbacks with Coumadin, obviously, Gotta do a bunch of blood tests, because the level's very important for us. With the Eliquis and Nels, you don't. But the Coumadin's easier to reverse, because we just hit them with some vitamin K and we're out of it, right? The other ones, we gotta do things, plasma, things of that nature to reverse them out of it if they had an accident or something. So there's pluses and minuses for both of them. Plus, Coumadin is like they almost pay you to take it, you know, where the other stuff is new and very expensive. So if your patient's got tight budgetary, Coumadin's probably the way to go.
You're so funny, because it is true, they push Coumadin on people.
Sure.
Please take our drug.
Yeah, they do. But we've been using Coumadin for, God, a long time. Stroke though, because of AFib, if they're not anticoagulated, it accounts for like 20% of all strokes. So it's a huge problem. It's something that we've got to deal with. Okay. Treatment goals, we got to get that heart rate down to less than 100. Now we're not talking the atrial rate. Remember, the atrial rate is 350 to 500, 650, whatever. This is the QRS complex, so the ventricular rate. We want to get that less than 100. Because if it's going too fast, what happens to our cardiac output? It's going to drop, right? Because we don't have time to fill and push the blood through. So we've got to get that below 100. That's our number one goal with AFib. And then our number two goal then is to fix it long term. But initially, if we can at least get it to, with a ventricular rate less than 100, then great. We got to prevent that clot formation. That ventricular rate controls priority. And then we want to convert back to sinus rhythm. We can do cardioversion, which is,
That's cool.
it's a lower electrical version of defibrillation, right? So when we defibrillate, we're starting the whole heart. When stopping the whole heart, when we do cardioversion, we're trying to just stop
They
the
do it like
atrial.
50 joules.
Yeah, we have to sync it.
Yeah.
Time-wise, we want to get it all in sync so that when we hit them, it's at the proper time.
I feel terrible for those people.
Hmm?
I feel terrible for them, because every time they do it, they're like, seriously? Really? Ow.
So you as a nurse, what can you do?
You know, tell them
Request to have
suck
them
it up.
sedated.
Maybe
Give
you
them
could give
pain
them some.
meds, don't give them sedation.
In anxiety.
Well, right.
In the
Maybe
ICU, we do.
give them a little bit
This
of
is the ICU.
pain
They find something
medicine, you know,
pain.
some Ativan a little bit, maybe just to calm them down. Because they're getting shocked. It's not fun. It's, you know, so if you can, as a nurse, you've got orders and stuff that you can make it less of an event for them.
Anesthesiologist will come.
The really bad ones are the ones you have to externally pace, because they're coming in with a heart rate of 10, and you're waiting for the surgeon to come in and put in an implantable pacemaker. And so you're externally pacing them, so they're getting shocked 100 times a minute externally, until the surgeon takes a shower and gets in his car, stops at Starbucks along the way to the hospital, right?
With AFib, it's always synchronized cardioversion, or can it be?
It's going to be synchronized, because we're going to try to synchronize it off of the QRS though. We're not really synchronizing it off the P waves.
Mm-hmm.
But we don't want like an RNT. We don't want to be blasting during the ventricular contraction and RNT, because then we can stop the heart completely. So that's why we just kind of watch it as much as possible. Can things happen? You bet. So that's what cardioversion. Amiodarone, drug of choice for AFib. Drug of choice. Most common for conversion and then maintenance afterwards, long-term maintenance. In the cardiac surgery world where I live, when they would flip into AFib like in the middle of the night or whatever, we would get amiodarone and we would do like 1 milligram a minute as a loading dose for about, I don't know, 4 hours or so until the bag was gone. And then we cut it in half. Then we would go to 0.5 milligram a minute. And we would run that out until we got them to convert. And then after that, we could go to PO to maintain it if they were able to take PO. So that's like the logical progression of it. And it's really not unexpected after heart surgery. We see a lot of it. Okay. ablation, we can go in through the cath lab, we can run a wire. If we think we know where the spot is, we'll run a wire in and then we'll like zap a particular area, killing that foci that's in that area, permanently damaging it so it can't do this. We can pull it out that way. Beta blockers, what do those do?
Increase cardiac output
Okay, increase our cardiac output, how?
by blocking the beta receptors. I don't know.
It slows, right, so it's slow, it adheres to the beta receptor sites, and it helps slow the rate down and allow for more filling, and so then we're getting better cardiac output because of it. Calcium channel blockers do the same thing, okay? So if somebody, for whatever reason, can't take a beta blocker, we'll do calcium channel blockers instead to try to do the same thing. We never, ever, 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 ever do them at the same time, okay? Because it would be an additive effect. All right? So that's an either-or situation.
Is ablation more common in flutter than fib, or is it because it's easier to pinpoint?
Right, ablation, yeah, we tend to do it in long-term flutter more, but we can do it in fib. If we've got like an area that we've zeroed in on 12 leads specifically, we can zero in on areas. We can actually, it's an advanced technique. So if you go into cardiac nursing, you'll get involved in it, but you can tell on a 12 lead which way that your current is going. Like if it was a pointer and 360 thing, you can tell exactly where it's going and what it's going around and things like that. So we can use those to help us pinpoint, say, oh, well, we've got a trouble spot right here.
And that way you can go in and just zap that spot.
Right, you can hit that spot and kill it. Kill that foci.
Do you damage cardiac tissue when you do that?
Yeah, yeah. You're looking for a permanent solution. There's another thing that we could do too, it's called a maze procedure. So if somebody's gonna have open heart surgery, and you'll get a kick out of this. So if we've got their heart open and they've had chronic AFib in the past, the cardiac surgeon will go on their atriums and they'll make slices in there, like a bunch of slices, like in ribbons, along the atrium. And then eventually those slices turn into scar tissue. And then it kind of redirects where the electrical flow is going. Because it's just on the surface of it, but it redirects that electrical flow. And hopefully then just brings it into the AV node like it's supposed to. You, if you're a cardiac nurse or you're an ICU nurse, and the patient had this done 2 days ago, the floor nurse is gonna call you and say, hey Dave, they did the maze procedure, but this patient's still on AFib. And you're gonna be like, look, how long does it take scar tissue to form? Right? Not 2 days. So it's one of those things that you gotta wait for the result.
Does that
It's down the
person
road.
stay in the hospital until they come out then?
Not necessarily. If everything else is stable, they can go home.
Okay.
Yeah.
Would they go home like with an Holter monitor or anything like that?
Eh, probably not.
No?
They would probably still be anticoagulated and all this stuff. Usually this is people that were on
Stuff
AFib
before.
protocol for a
Okay.
long time. And since we're gonna be in there anyway, we're trying to fix it.
Oh.
Yeah. Okay. Need a little break?
Yeah.
Are we
Yeah.
gonna get through all of this today?
I don't know. We'll see. Let's take 10 and then we'll come back to this.
Okay.
CPR, you might, in case Sue's getting pretty old.
Snap! It's your birthday today.
Okay. They're pretty much the same though, aren't they, all along there?
They're jagged sawtooths.
Jagged sawtooth, that's classic for A flutter. So if you had a question on a test sometime and it asked you about sawtooth, what are we looking at? A flutter. If we saw this on the test, we would be looking at A flutter.
So
So the point is, one of these foci has gone kind of crazy on us, right? So we've got, it's an atrial tachy dysrhythmia for one foci. And that's why they all look the same. Also notice, because of that, the electricity is only getting down certain time, whether it's 3 in between or 4 in between or whatever. But is the QRS rhythm pretty steady there? It's not really irregular, is it? A flutter it is, or a fib it is. A flutter is pretty regular. Okay, so that's a big difference. What's our ventricular rate on this patient?
70?
So about 70, right. So that's not as much of an issue. We're still going to lose some of that atrial kick though. So we'd like to get them out of this. Sawtooth-shaped flutter waves rarely occurs in a healthy heart, because why would it? Coronary artery disease, hypertension with long-term, valve disorders and that sort of thing. But it could also come up from some drugs like digoxin, quinidines, especially, remember those things, we've got a pretty narrow range that we can use with them. And if we're starting to knock on the ceiling of it, you might see the safe flutter popping up. So we can use that as a little bit of a warning sign, right?
So if the patient was on digoxin and had a flutter, would be, like, if you use Digibine, would that help the a flutter or no?
Well, it depends. So at that point, I mean, if I had time, if the patient wasn't really symptomatic in that, I'd probably draw a dig level and see where I'm at,
Okay.
you know. And then we could go from there. The atrial rate, obviously, on AFib was what was it, 350 to like 20 million or whatever it was, right? It was fast. Here on atrial flutter, it's 200 to 350, so it's a little bit slower atrial rate than fib is. Still not good though for atrial kick, obviously, right? But our QRS complexes are normal because everything's making its way down the normal pathway, and so we're not irregular. You consider this cold? Come on.
Well, I went out in my sweatshirt.
Oh. I generally don't wear a coat if it's 40 or above.
You one of those ones with the shorts on still, right?
Yeah. Clinical significance, same thing. We're going to lose some of that kick. We lose that kick, we decrease our cardiac output. And that could also long-term cause serious consequences like heart failure, increased risk of stroke, etc. Coumadin, given to prevent that possibility of stroke. Do you remember at Coumadin, we check an INR, right? International Normalization Ratio is the blood test that we do. Where should that, what numbers should we be in between?
3, right?
7.
2
to 3.
to 3. Right, it's therapeutic. Okay. If we took our INR right now, it probably would be what?
Like a 1, right?
A 1. Yeah. Because anytime you see ratio, what does that tell you? That's usually 1-to-1 ratio. Right? So Coumadin, if we're in a therapeutic range, is usually 2 to 3. So about double to triple the anticoagulation that we normally have. Treatment goal, slow that ventricular response if it's up above 100, right? So we need AV block. How do we AV block?
Medication,
Okay, what kind of meds?
calcium, beta.
Beta blockers, calcium channel blockers. Do we do them at the same time?
No.
Never, ever, ever. Right. Antidysrhythmics to convert the sinus rhythm. So there we're back to like our amiodarones, lidocaines, etc. Cardioversion, we can hopefully convert to sinus in an emergency if we're really symptomatic and the patient's struggling. And we can do radiofrequency catheter ablation. And because it's more common in flutter for us to ablate, we can run the wire up, cath lab, find where we're at, zap her out, right? Questions so far? So those are atrial dysrhythmias. So let's talk a little bit about ventricular arrhythmias or dysrhythmias. For some reason, it's just a practice thing from, you know, when Florence Nightingale was shaking her booty in Crimea or whatever, that when it's a ventricular, usually we call it an arrhythmia, and if it's atrial, we tend to go more to dysrhythmia, but they're interchangeable, really. So I don't know why we do that. Premature ventricular contractions, PVCs, premature occurrence in that QRS complex, big warning sign for oxygenation. That's the first thing I check if I start seeing PVCs is oxygenation. The second thing I do is run a complete metabolic panel, and I'm looking at all my potassium, my mag, my calcium. Okay, very important. VTAC occurs when there's 3 or more consecutive PVCs, usually in a row, and then you'll see the nurse start to get up and go, oh, I'm going to go check this out. Okay. VFib, severe derangement of the heart. Irregular waveforms, various shapes and amplitude. Quivering ventricle. This is a code situation then.
In a quivering ventricle.
Yeah, this is a code. We're going to call a code. Okay? You're doing CPR. How many compressions a minute are you going to do? 100. Good songs for that?
Stay alive.
Another one bites the dust.
Another one bites the dust is a great one. I love it. Okay, quivering ventricle. All right. Here, we've got a single PVC, right? We're pretty sinus here as we're going along. Okay. But we had a PVC fire here. And so it's not going the normal pathway, right? And we get this big honking PVC thing happening. And if we see one every now and then, we go, are we all that concerned? Probably not. But when they start getting in a row or multiple ones together, then we get really concerned.
If it's like one, like the top one, does it usually like relieve itself or what?
Yeah, so, you could have a misfire for
Some weird reason.
whatever reason, right? Because we're humans and we're not perfect.
Right.
Especially when people are sick. So if it's like an isolated one and it's every now and then, I would chart it, they had a PVC, whatever. But when they get multiple ones, then we've got to investigate immediately. I heard somebody say trigeminy.
Isn't it bigeminy?
This would be tri.
Oh, yeah.
Every third one. Okay, every third one's a PVC, so that would be trigeminy. Every other one is bigeminy. Okay. So every third one we're getting a weird PVC thing. And I've seen a little rabbit ear here, so this is probably coming down because of a bundle branch block, but that's for another day. This is definitely something that you would want to alert the physician to if it's not been historically happening, if it's something new. Not as alarming as them directly in a row though. Okay, because when that's happening, we're getting dropouts in our cardiac output. If you get 5-6 PVCs in a row. So during that time, our cardiac output is get next to nothing. So it becomes a big problem. What do we see? Hypoxia is a biggie. Ventricles are very sensitive. They're big muscle and they're squeezing all the time, right? They're squeezing 90 times a minute or whatever it is that they're doing on your heart rate. They need that O2 to keep doing what they're doing. Stimulants, caffeine, alcohol, nicotine can also cause PVCs, as can epinephrine and digoxin. Hypokalemia is a big one, and associated diseases. MIs, mitral valve prolapse, heart failure, coronary artery diseases. Myocardial infarction, what's going on when we have a myocardial infarction?
Heart's overdone.
Okay, what's the matter with the
It's
heart?
not
Part of it is the
overload.
It's decreased cardiac output because the electrical current is being disrupted.
Well, the heart muscle itself has interruption of its blood supply to it. Because it doesn't supply itself from the inside, the blood that's going through it, right? We've got coronary arteries on our heart. Let's take a little quick look at that on my drawing. Just so we're kind of clear on that. Once we go through the whole heart in that, coming off of it, we've got the aorta, right? And that's going down the body. We've got the carotids come off of here, etc. And we've got the valve, aortic valve, that opens it up. If we're looking at the surface of the heart, you've got the widowmaker, you've got the circumflex coming around, the different coronary arteries. When do arteries in the body get supplied with blood? Is it during systole or diastole? Systole, right? Every artery in the body. When the heart squeezes, that's when it gets shot down the aorta and through every artery in the body except the cardiac arteries. So these guys, they do not get perfused during systole like the rest of the arteries in the body do. And there's a reason for that. It's kind of a design flaw. They come off of the aorta like right here. Okay? So when the heart is doing systole, it's squeezing, right? So that's when we get systole, the aortic valve opens up and shoots blood out through the aorta. These are too low on the aortic tree there. So when that valve is open during systole, the coronaries are blocked. Okay? And when that valve closes, under the lower pressure time, the diastole of the heart, is when the blood actually kind of backflows into these coronary arteries. It's a little bit of a design flaw. Okay? Maybe in people 2.0, they'll fix it, but right now it's an issue.
They could fix depression.
So, just as an example, just to think about it in reference, we see the carotids coming off, right? Those are obviously systole. They're coming right off of the aortic arch, so they're getting a huge flow of blood up to our heads, right, during systole. So, when our carotids are getting blocked over time, because we eat at McDonald's or whatever it is that we do, they can be as much as 90% blocked, and because of all that pressure of systole is shooting it up past there, and it's still perfusing our brains. Okay? But these guys, when they're getting little blockages or whatever, and they're being perfused during low pressure, so those blockages don't allow as much pass. Now we're not getting blood flow to the heart muscle that's working very hard all the time. And then we get damage. That's a myocardial infarction. See why? So then we got to go in there and fix it. Right? We go to cath lab, run a wire up, find the blockage, try to get through it, pull it out, put a stent in, whatever it is we're going to do to open that back up so that we've got good flow, because that heart muscle needs it. And while we're doing all that, we want to take away the work of the heart. We want to slow down the rate, right? So that it's not working so hard, lessen the damage. So that's all the things that we're doing during that time. Follow? Mm-hmm. All right. Okay. So all of those things can associate with PDCs. Ventricular tachycardia is sustained longer than 30 seconds, what we actually call it VTAC, causes severe decrease in cardiac output. Or non-sustained is less than 30 seconds, but we still have a dropout of cardiac output. It's a bad thing. We don't want to have our cardiac output fall off. Can be stable or unstable depending on whether or not the patient has a pulse. Okay. How could the heart beat and we're not getting a pulse peripherally? Why is that?
Because it needs to be above 80 to get down here.
Well,
Or maybe
right, so our cardiac output has fallen off, right? So our output is so low that we're not perfusing out to those areas. That's why we're missing the pulse. We become pulseless. Not because the heart isn't doing something, but it's not doing it well enough. So we wind up being pulseless, and that's the worst situation then. Okay? Associated with all the same things that we've talked about before, and long QT syndrome. So from our QRS complex to our T wave, that segment gets longer and longer in between before we have repolarization. Okay, some drugs cause that, but now we're not repolarizing and firing, and eventually the whole thing drops out. So that's QT syndrome. Very bad. Drug toxicity. Digoxin is a good one for that, right? But there's many others. It can also be caused central nervous system disorder because our brain, the sympathetic parasympathetic system, can be out of whack and then not telling our heart to speed up, slow down, etc. Results: hypotension, sometimes very severe. Pulmonary edema, because we're backing blood up back into the tree, back into the lungs. Decreased cerebral blood flow, we're not getting enough up to the brain. And cardiac or cardiopulmonary arrest. So we have to identify what's going on and treat it in order to avoid this. We're going to do IV amiodarone, procainamide is another one, lidocaine. You don't see it too much anymore, but some cardiologists will call for it, or even doctors in a code situation. If nothing else is working, you'll hear the doctor say, "Well, screw it, let's try some lidocaine," right? Because we tried all the other stuff, so we might as well give it a shot. And a lot of times it works. It's an old drug, but it still works on some people. Cardioversion with amiodarone or lidocaine post-procedure. Beta blockers again, slow it down, lessen the work of the heart. CPR defibrillation, first line of treatment if they're coding on us, obviously. Followed by epi, and then amiodarone if it's VTAC without a pulse, if we're pulseless. Okay. Did we go over what do you do during a code? We've done this before?
Don't panic.
Okay. All right. So you're the primary nurse for this patient. Okay. Let's say it's your patient and they just coded.
Mm-hmm.
Document.
Okay. Somebody documents, right?
Mm-hmm.
Somebody's
Doing
pushing
meds.
drugs.
Yeah.
Somebody's doing CPR. We got all kinds of people doing everything. Angel, come here, man. So I call the code. Angel shows up from the ER. She's the doctor down there. How much about this patient does Angel know?
Nothing. You have
Not
to be the
a
one that's
darn
telling.
thing, right? So my position during this code is I'm gonna Velcro myself to Angel. Okay? She's gonna have all kinds of questions about this patient. What were the labs? What was going on? What's this patient's history? Yada, yada, yada. I don't need to be recording. I don't need to be pushing meds. I don't need to be doing CPR. I've got to be on her and talking with her so that she can get the best treatment for this patient. That's what you do if you're the primary nurse during code. Is you stick yourself to the doctor. Okay? It's the only way. You can sit down.
So like if you're talking like, that's okay, like in floor nursing,
Yeah.
it's so different from each.
Yeah, each
department,
unit
so-
is very different on what you do.
True, but the doctor's still gonna have questions, right? So a lot of times they'll come up from the ER, they'll bring an ER nurse with them. They won't ever do it if it's in an ICU because we'll kick the ER nurse out of there. We say, get out of it.
That's what I always do.
And I always kick them out.
The techs go with more often than not.
Text to do CPR, which is great. ICU, the last ICU I was in, we had a no nurse over 50 doing CPR role because,
Go hard.
you know,
Lucky
Get
you.
it, girl.
Double code.
yeah.
Right, exactly.
You didn't want to wind up being a patient.
Oh my
Who's done
gosh.
CPR? I've done it many times. Who's done it?
Not on a real person.
Oh my God,
Don't go
it's about
first.
2 minutes. What do you feel like?
Minutes.
Speed.
It feels like forever.
Yeah.
But don't ever go first, I always go second, cause then all the ribs are
I go
cracked for
second.
you.
Oh,
And you
wow.
don't
When
have to,
I
like,
did
crush
CPR,
it.
luckily there was an ambulance crew that was like
Ready to go.
ready to, like they were there and they're like, well, What year do you guys want to
They put the
know?
You
Lucas
never
device
realize
in.
how out of shape you are until you have to do CPR.
And the
Yes.
next day you
Yes,
wake
you're
up sore.
sweating and like.
Oh my God, yeah. So that's a young person's thing. Let the text do it.
Remind me to
You're
tell
gonna have
you-
to slow them down. That's why you gotta know that song, right?
Oh God, there's some where they're like,
It's nice though to have
That's
the,
right, so you're looking at the monitor.
it's nice to have the
You need to slow
monitor,
down.
or like the crash part with the monitor in front of you, because then you can see. like,
Yeah.
there's
the
also
track.
that pump
Sure.
that goes slow down, speed up.
Oh,
Oh, I would be unplugging that.
Oh God, it's annoying. It's so annoying.
Remind me to tell you my ICU
Okay.
incident. I'll tell you that way. After.
Yes, just go ahead.
Anyway, well, like different floors, okay, I understand it. Like, usually I was a charge nurse in ICU in my later days, and I was always on the rapid response team and that. So we would go to the codes. But I would grab the floor nurse and say, this was your patient, right? So come with me. And I would get her right onto the doctor, you know. Doctor doesn't know. The only trouble with floor nurses is sometimes they, you know, maybe they got 6 patients, 6, 7 patients. And so you're asking them, well, what was the K? And they're like, I gotta look it up, because they don't have it all memorized. An ICU nurse, there's no excuse for that. You've got 1 or 2 patients, you should know these values on your patient, especially the sickest ones. You know, it should all be committed to memory. And so when it's needed in a code, you just spit it out, and the doctor can do whatever it
Or
is
you
that
do
the
your
doctor's
due
gonna do.
diligence in the beginning, and you look up all your values and write them down if you can't remember.
Right.
Well-
That's all my-
But they could have drawn different labs.
I've known a lot of nurses too, especially older ones, that have a cheat sheet in their pocket. And
They make
and there's
me
nothing
draw
wrong with
them.
that,
No.
you know. But the point being, don't be off doing something else. You need to be available for this physician so you can give him all the history, because he knows nothing, he or she knows nothing about this patient. So it's on you to do that. You're the primary nurse, right? So, yeah.
$5,000.
Here's some VTAC. This one. Now this, we might feel a pulse, we might not in this situation, right? But this is like VTAC. If you think of VTAC, these are multiple like PVCs running all together, right? And you can see that now, because now you guys are experts on rhythms and stuff. So you understand all this. You know more than 80% of the nurses out there, I'm telling you.
That's Wolf Parkinson's line.
This is an emergency, okay? If they're not sitting up and talking to you, we're gonna be doing CPR at this point, right?
Yep,
Yeah, because we're not gonna have
we're
much.
shocking.
This one here is kind of unique. You see how it's just like that? This is what we call torsades. And it's a type of VTAC that we see almost exclusively when they're low on MAG. So remember earlier I was talking about MAG? If you see this here, this torsades de pointes is what it's French for twisted ribbon, is what the name means. So doesn't it look like a ribbon
Yeah.
twisted? You see that immediately in your brain, you're going, wow, my MAG level must be screwed up to see this. So usually we'll give 2 or 4 grams of MAG and try to pull them out of it and do it really fast, okay? Pretty rare to see this, but when you see it, it's got a unique signature to it, and it's something that you can act on pretty quickly. VFib is the almost worst one you can get, almost, where the ventricles are quivering and no effective contraction, the heart rate's not measurable at all. We're gonna be pulseless, of course. Here's all the reasons why we could be in VFib. And you notice in here, even hyperkalemia can cause it, but hypoxia is the biggie. Acidosis can cause this as well. Drug toxicities. They're unresponsive, they're pulseless, they're apneic, they're not breathing, right? If they're not treated immediately, that's it. It's all over. CPR, we do ACLS. If you're a nurse in an ER or an ICU, you'll be ACLS trained. And we go through all those things all the time. Defibrillation, do not hesitate to use defibrillation. You have it on a crash cart. So if you're in a hospital, you're in an ICU, you're in an ER, they're in VFib, hook those paddles up and blast them. Okay, you don't wait for the doctor to say, yeah, okay, go ahead. No, Hit them now. The sooner you can get them out of it, the better their survival chances are.
Well, and the decrease, you don't scar the heart as much.
Yeah, well, the point is just, the sooner the better. And this is why we've got those little portable defibrillators out everywhere now. Gwen and them just used one. Do you know Gwen?
I saw that in the news.
Yeah.
Oh, Gwen.
Yeah.
Costco.
Yeah, she was at Costco and they found somebody down and so she was doing CPR and one of the employees at Costco came out with one of those little portable defibrillators that talks to you. Those things kind of make. She's in
The culvert behind us?
my Thursday evening patho class right now.
Oh, so she's new.
Yeah. So 5th semester.
I was gonna say, you're not that new, girl. You wouldn't know.
Yeah, we used to do patho in 3rd, but now we do it in 5th.
Oh, okay, that's what.
Yeah.
Because they're wicked training, probably.
Yeah. Well, I don't know.
Well, not with you. But
That's probably not their why they decided to do that. Anyway, they got one of those things you hook it up and talks to you and it decides whether or not to shock because it's looking for a shockable rhythm, right? If you're in a hospital, you're not using those things. You're looking at the monitor and you're deciding, is this rhythm shockable or no? That's up to you. Doctor's not there yet. You're in charge. You're the RN, right? So until a physician gets there, you're the boss.
They haven't used paddles anymore.
Yes.
Yeah, I've used paddles if I don't, if I want to hit them like right now. Sometimes I'll even put gel on them. Sometimes I won't. I burned them sometimes, but I want to get them
You
going.
gotta do what you gotta do though.
Yeah. Anyway, that's the thing with VFib. Defibrillation as quickly as we possibly can. If we identify that it's a shockable rhythm, we want to do it. Do not do it to them if they're an artifact, which is what Tricia was talking about earlier. Artifact. So if it's looking like VFib,
Go in there and actually check the patient.
yeah, go look at your patient. If your patient's sitting up and they're on their computer or whatever, it's not VFib. It's artifact, which just means that the leads are jumping around or maybe one came off.
But they're just moving.
Here's how VFib looks. A real case of VFib. That's no organization at all to that rhythm. So this person's in trouble.
Is that kind of I was just gonna ask, is that a PDA?
PEA's coming. So we kind of already approached it. PEA, we can see that the heart on the monitor is doing some kind of a rhythm, but we're not getting a pulse. Why?
Because
'Cause-
it's not pushing her down.
Right, so we're not getting cardiac output out there. So that's why we're in
Do
PEA.
that. That was scary.
Yeah, asystole is obvious, right? Flatline. And our heart blocks, we said that there's 4 types. First degree, second degree, type 1 and type 2, and third degree. And we could go over what those are. So you ever see a question, how many heart blocks are there? 4. Okay? Here's a first degree heart block. And all it means is this PR interval. The PR interval is greater than 0.20 if we measured it out. So if we're looking at a rhythm strip here, these little teeny tiny micro squares are 0.04, but this bigger block, like this, the distance from here to here, is 0.20.
So what did you say it was?
Greater than 0.20. So if we look down here, we could see that from here to here is bigger than one of these blocks. That's a first degree heart block. So it's taking it too long to get through the atrium and through the AV node. So we've got that PR intervals extended. That's all a first degree block is.
Just need some space from your partner.
Right, it's just a little longer. This
Your
interval
first
here.
degree, so you're not divorcing it. You
From
just-
here to here.
There you go.
Okay, see, it's bigger than this one block, first degree block.
Okay, I get it.
Okay? Type 2s are the same, except they present a little bit different. We used to call it Mobitz. Now, don't worry, Winky Bach, but we don't do that anymore. So we call it type 1 and type 2. In type 1, again, we're looking at our PR PR interval, okay? This first one's kind of normal. Oh, second one's getting a little longer, right? Third one's getting even longer yet. And then after that, we drop a QRS complex because it can't fire. Because it's not getting through. So it's like longer, normal, longer drop is on a type 1. On a type 2, we're just seeing the pattern where here's our PR, it's the same, and then we get a drop. So we're getting some kind of resistance, but not that elongation that we're getting in the type 1. That's the only difference. Either way, every second, third, or fourth QRS complex, we're dropping one. Okay, so that's a second degree block. Follow?
Yeah.
All right. Third degree block, the worst one, right? There's actually no longer a relationship between the P waves and the QRS complexes. We've got a complete blockage, whether it's the AV in the AV node or whatever. Our electrical signal's not getting through. So we've got our atrium has got like an independent rhythm of its own here. Looks like our atrium's going, I don't know, 60, 70 a minute. But it's not getting through to kick the ventricles. So the ventricles are falling back on their escape beat. All right, so what's our ventricular rate here?
20.
Like maybe 20? Yeah. Now, I heard atropine, and atropine's a good idea. So in this case, we would try atropine, okay? If it's a physical block, atropine's not gonna help us.
So they would have to do a cap.
Right. Well, we're gonna put a pacer in that case, right? Pacemaker. If it's something because of the parasympathetic nervous system or whatever, atropine, then all of a sudden we'll see an increase in the rate. And then we know, okay, we're not gonna do a pacemaker, we're gonna figure out what's going on. So we always try atropine to see if it works. And when it doesn't, then we go, well,
You cry.
okay, we're gonna do pacemaker. So what am I gonna do with this patient at this point?
Put them on the pads.
Put the pads on them.
Put the pads on him, right, and I'm gonna hit pace. I'm gonna externally pace him till we get the surgeon in, right, and he's gonna put in a permanent implantable pacemaker. And they're not gonna like it,
But there would be hopefully safe.
yeah. So those are the blacks,
Okay,
all right?
pacemaker?
Leads us into pacemakers, we were just talking about that, so we need the pacemakers. Could be temporary or permanent, temporary being even, externally paced on the pads, or we could go in through the femoral, we could run a wire up and pace that way. Or sometimes from heart surgery, we have wires that the surgeon will leave sticking out of their chest, and we hook up a temporary to it and pace them with a temporary box. So there's many different ways that we can do the temporary pacemaker. We can do all the settings on them, the different modes, whatever it is that we want. Different modes, asynchronous is just a fixed rate. So if your patient is one that, their heart was beating at 20 a minute, and it's some kind of mechanical block, they're probably gonna have a fixed asynchronous rate. We're just gonna dial that in, we're gonna say, I want them to beat 90 a minute, and leave it at that. Demand detects when to fire. It tries to fire with the person's rhythm. And anti-dysrhythmic is overpace or shock should something occur. So different functions on it, like you see VVI, DDD, all that means. Sounds complicated, but it doesn't. The first letter indicates what chamber gets paced. Are we pacing atrium? Are we pacing ventricle? Or are we pacing dual, meaning both? That's all. The second letter is what chamber are we sensing? Okay? So we've got the machine sensing if the heart is doing something on its own. And which chamber is it? Atrium, ventricle, or dual? So then it's looking at, okay, in this one, I'm looking at the ventricle, I'm not seeing it, that's when I'm going to do some kind of intervention there, right? And the third letter is it inhibited or triggered based on that intrinsic activity, okay? So on a VVI, the machine's sensing the ventricle, it's pacing the ventricle, but it's inhibited. So if it senses that the ventricle is firing, it's going to sit there and do nothing and wait, okay? That's all that's telling us.
Then what does the D stand for?
D is dual, so it
No,
will
for the
inhibit
third letter.
or trigger based on the information
Okay.
that it's getting, yeah. So let's look at, if we're looking at our rhythm strip or our monitor, we can see that somebody's paced. You see these here? These are pacer spikes. Okay? This one is apaced, atrial paced. We see a spike, it's triggering a P wave, and then that wave is going all the way through and doing the QRS complex and everything. Kind of like the heart did it, but it didn't, right? We did it mechanically with a pacemaker, and it's going through. So that's apaced. Here's dual. It's a little different view because it's going negative, but it doesn't matter. So we see a spike before the P wave, so it's apaced, and we see a spike before the QRS, so it's also V-paced, so it's dual. It's AV-paced, right? We would do this when we were pacing out the atrium and it's blocked, like a third-degree block, and we can't, so no matter if we pace the atrium, it's not getting through to the ventricle. So we're doing a secondary pacer spike in the ventricle to get it to kick. So why bother with the atrium then?
Because you need it.
It's that 30%, right, of our cardiac output. So we're just mechanically doing what the heart would do. We're filling the atriums, we're firing them, they're preloading the ventricles, and then we're firing the ventricle. And we see these spikes, AV spikes, along the way. So you can tell that it's doing what it should do. Kind of clear?
Yes.
Well, and on a telly, you can see it because they turn white. when
Yeah.
they're straight.
Yeah. Yeah, they're white. On the paper, they're just kind of a spike, but yeah, on the monitor, real easy to see. And you can turn them off and on though, on the monitor, by the way. So if you're like expecting to see them and they're not there, before you freak out, right click.
Oh, and turn them on.
Yeah, they may be, somebody turned them off because they didn't want to look at them or whatever.
Oh,
Yeah. ICU nurses are funny that way. They like to see rhythms that they like to, the way they like to see it, and maybe you want to see it different. So,
yeah.
post pacemaker insertion. If we're doing an implantable, they come back. Complications. Well, they cut here. They make a pocket, right, to hold it in, and they run wires into the heart. So these complications all make sense. Bruising, collection of blood, right? Pneumothorax, because in that area, if they push the wire too far one way or another, they could drop a lung. Infection, just like from any surgeries. And arrhythmias, if it's not really sitting right or it's miscaptured, etc., we can have arrhythmias occur out of it. Restrictions after pacemakers are inserted. They cannot raise their arm any higher than their shoulder for 1 to 2 weeks. Okay? Because if you're pulling up like this, if you do that, you could feel on your pectoral muscles here, it's pulling. Feel that pulling? And so you can pull the wires out. We got to let that heal in there. All right? And we can get lead dislodgement then. Fall precautions for them. We don't want, brand new pacemaker, you don't want them tumbling down on the ground, right? Airport detectors, we give them a little card, and TSA don't care anyway if they got the card or not. They're still going to wand them, but at least they know to look there. You could feel pacemakers under the skin.
Oh, you can see them.
Yeah, you can see them.
Yeah.
Unless they were chill.
MRI, can they have an MRI again ever?
No.
Negative, right?
Turn it
Negative.
off.
Huh?
No, you
Unless
still
you want to
can.
turn it off on them.
No, it doesn't matter if it's off or on.
Oh.
No. Especially the wires. The wires are metal,
Yeah.
right? So if they're in an MRI, those wires will burst into flames from the magnetic energy. Yeah, we don't want to do it.
That sounds like a good
No MRIs.
They don't make MRI safe ones?
I think they do nowadays make some MRIs safe. Would you risk it?
No.
No?
I would. No.
I mean,
I've
it's
seen
Well,
what it
like,
does to a
if you have
stethoscope across
titanium
the
rods
room,
or
so.
anything, those are not magnetic, so it won't.
Right, if they're made of a certain metal, yeah.
Yeah.
I wouldn't do it. Pacemaker complications, failure to capture is the first one. So we're seeing these pacer spikes. See here, there's no QRS after it. So the pacer spike didn't capture the heart and cause a QRS. So in this case, if it's an outside one or a temporary one, we'll turn up the voltage a little bit till we get capture, so we can watch it on the screen. We just turn, and then whoop, got capture. So that's a good place. If it's an implanted one, we got to call up the company. They get on a computer and they interrogate the
You
pacer.
can actually do it now, like through the ER, because they put like machines in there, and you just put it over their pacemaker, and it sends it all via like internet or whatever. It's really cool, and like you can see it too.
Here's the scary thing too, because we've done it in the ICU too. We call them up and say, hey, because we've got the card, right?
Mhm.
So they've got a code on there for that pacemaker, and they get on the internet, and they, through the Wi-Fi, they connect to this person's pacemaker now, and then they can adjust it. They can turn it up or down. They
So
can
that
add
means anybody
voltage.
can hack into it.
That's the thing now. Yeah, so wait till somebody hacks in and starts goofing with your pacemaker.
Is there certain somebody who wants to have a pacemaker? Just
Anyway,
Oh my
yeah.
god.
Anyway, that's failure to capture. So if you see this is kind of a problem. So we need to fix that right away, because we're not getting captured. Failure to sense is another problem. So here, this pacemaker should be sensing these QRS complexes and not firing, but we're seeing that sometimes it's firing too soon after because it didn't sense that the QRS fired. So we would go in and do the same thing. Instead of adjusting the voltage, now we're going to adjust the sensitivity so that it recognizes those spikes. This is a really poor one. Failure to pace, no output. So somewhere along here, this pacemaker should have went, oh,
I gotta.
we got nothing happening. I
We
should
need some help.
deliver a shock, right? But it's not. So it dropped out, and then we're getting this big honking PVC because the ventricle's doing this escape beat thing. Probably a dead battery. This would be a great time, externally pace them. Call the doctor, say, yeah, time to change out this unit. Okay? Good for now?
Yeah.
All right. Next week with Michelle, then she can take you up on shock.
Here's a scope where you don't know where.
super exciting.
Okay, everyone will start to filter back in. Don't close it all the way because Nick's not here. He'll be banging on the door. One of those things. Okay, I have to say that I'm actually kind of jealous that Dave gets to teach this class because this is one of the classes that I absolutely love to teach. He can keep patho. All right, what do you guys know about shock?
There's 4 types.
Besides the fact that there's 4 types, if I told you that I'm giving you a patient that's in shock, what do you think that patient's going to look like?
Diaphoretic.
Probably diaphoretic. Color do you think they might be?
Pretty pale.
Maybe pale, maybe blue, mottled. Has anyone ever seen a patient that's mottled that's like a purplish color?
Yep.
Okay, so that's someone whose actually tissue is starting to die, but hasn't completely died yet. If you see someone who's in shock, you'll see that the core may look nice and pink, because where do we shunt blood when we're not doing well? To the core. The body instinctively wants to control the heart and control the brain. It could care less about your peripherals, could care less about your kidneys, could care less about your gut. Why does the body always shut the kidneys down first? In anything that happens, why are the kidneys the first to go? Ever heard of dialysis? Because we can keep someone alive if their kidneys shut down. We just put them on dialysis. The body knows. The body knows that the kidneys aren't the most important organ. So you're fighting between the heart and you're fighting between the brain. So with shock, when someone is actually in shock, you don't have very good tissue perfusion. Your extremities suck. I'm going to tell you that right now. What kind of pulse do you think you might feel?
Weak and thready.
Weak, thready? Someone who, especially if they're in hypovolemic shock, where they have no volume in their body. Okay? So yes, there are 4 stages of shock. Obviously, when someone's in shock, what are you truly trying to treat? The underlying reason that they're in shock in the first place. So if it's cardiogenic shock, obviously, what body organ's being affected? The heart. Okay? Hypovolemic, those are your trauma patients. Anyone who's had any form of trauma, anyone who's had any massive hemorrhaging for whatever reason, your OB patients can go into hypovolemic shock. Who wants to work OB here? Have any OB nurses? OB is not all roses and sunshine. Who works in OB currently? It's not. There are times, I will tell you guys, not long ago, I'm going to say, wasn't even a month ago. I've been a nurse for almost 18 years. I responded to my first newborn code because I was house supervisor and they called a code in the OB unit and it was for the baby. I thought my heart was going to sink. I was like, oh my God.
Scary.
It was absolutely scary. The one thing I learned about the neonates, though, is most all of it is oxygenation, right? It's all respiratory for them for the most part. So as long as you keep their heart rate up, you don't necessarily need to start CPR, but you need to breathe for them because breathing is usually what's impaired. So there you can, obstructive shock, that's some of the things that you're looking at. The baby we actually got the baby to respond and he actually started to do well, but we had to transfer him out because we are not equipped to deal with a newborn that's just coded on us. But yeah, it was like I was standing up there and I was like, oh my God. Oh, I've been in a lot of codes, but not a newborn one. Even in all the times I've worked in the ER, I've never had to deal. I've dealt with pediatric codes, but not newborn.
I remember when that happened.
Oh, geez, that was a day from hell.
Yeah.
Okay, there are stages to shock. It doesn't matter. I don't care if you guys, what category of shock you're in. They all have 4 stages that they go through. Understand the difference. The idea is with shock, you want to initially get it to where you're actually trying to get it in between these 2 stages. Who here has heard of sepsis? It's in the hospital everywhere, right? We talk about septic shock all the time. You guys now have a sepsis sheet that pulls down. As nurses, you guys will be doing this. It triggers anytime you answer certain questions. It's going to trigger your patient to be a sepsis alert. We know by evidence now and the hundreds of thousands of charts that have gone through chart review at every hospital, we know if we can identify somebody who's going to go into shock, we can treat them and they can have a good outcome. If the longer we wait to identify when someone's is going to go into septic shock, the higher the mortality. That's why so many hospitals now, sepsis is part of your rapid response teams. If you go work up at Big Freighter, the rapid response team, that's all they do is circulate through the hospital, walk around. Anyone who's triggered as a sepsis alert falls onto the workload of the rapid response team, and they actually go to the patient floor and they go look at the patient. They talk to the nurses. How is your patient doing? Do you have any signs or symptoms that I need to be aware of? Because the minute you call for the rapid response team, they know exactly what's going on. So if you get down here into the irreversible stage where you have total body failure, organs, liver, lungs, kidneys, the more organs that are affected, the higher your mortality. right? I have less opportunity to get you back. Kidneys always go first. Always, 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 always. That is why your urine output is so important. When an aide comes to you and says, my patient has not peed in the last 4 hours, and you're like, holy crap, they're getting 200 an hour of IV fluid. Okay, you've put a liter in that last 4 hours and they haven't peed once. Something's wrong. You got to do a little digging, right? Med-surg nurses. This is where they get a little complacent. And you have to come back and always remember, check your labs. Understand what your labs mean. You don't have to understand everything about the lab value, but there are some key ones you should know automatically. BUN, creatinine, GFR. What is that gauging? Kidney function. I could care less what the rest I could care less what the urinalysis looks like 9 times out of 10, only because it's usually contaminated. So I don't even look at my UAs unless they were from a sterile clean catch or a sterile catheterization. I hardly ever look at them. I always look in my chemistry panel and I want the BUN, creatinine, and GFR. GFR different for nationalities? Yes. Yes, it is. So it's very much a, you have to know the ethnicity of your patient because it doesn't tell you when you're looking at the labs, right? You don't know unless you've gone and seen your patient and you're like, what medical diagnosis really affects the kidneys hard? 2 of them right off the bat. Diabetes
Yep.
and hypertension. Hypertension stems from the kidneys on a lot of patients, correct? Adrenal glands, renal, renin, intensio system. Okay? So, shock. The one thing about if you can compensate and your body is able to try to restore homeostasis, this is a good sign. Once you start going down, progressive shock, this is something that is really hard to come out of. You're starting to affect more and more organs, and you're actually less likely to compensate. All right, let's talk about cardiogenic. I shouldn't have to tell you that these can be your common causes of cardiogenic shock. MI, pneumo, tension pneumothorax. What's a tension pneumothorax? First off, what's a pneumothorax?
With errors and then pleural
Okay,
space.
so one of your lungs is collapsed, correct? So what's a tension pneumo? When it starts to push, because you've undiagnosed the pneumo for a long period of time, and then all of a sudden, since this lung can't inflate anymore, this one's been inflating and has no more reserve in it, and it's been inflating for both sides. You start to push. What's the last sign of a tension pneumothorax? What's a late sign?
JVD.
Not JVD.
Tracheal deviation.
Tracheal deviation. That's a late sign. If you wait and notice that on your patient, you best hope and pray that someone can get a chest tube in quickly on the other side. Always treat the underlying cause of why you're in shock in the first place. So if it's because you have severe hypertension and that's why I'm in cardiogenic shock, treat the hypertension. What kind of meds can I put someone on that's in severe hypertension? Okay. Cardine. Cardine's a great one. We use cardine a lot in the ICUs and step-down units. Okay. There are some patients, yes, you want to keep their blood pressure high, but not typically. There's very few patients that you want a high blood pressure. So cardine. Well, hello. Mitral valve. What can go wrong with the mitral valve? That's usually the stem of all your cardiac problems if you have regurg or stenosis. It's usually the mitral valve. Where does the mitral valve sit? Woo-hoo, back to anatomy. Let's go back to the dark ages. Let's put a little light on your A&P. Where's the mitral valve? Left side of the heart, in between the left atrium and the left ventricle, correct?
Yeah.
Okay, where's your tricuspid valve?
Yeah, right side.
Right side. So typically, if you have left-sided heart failure, it's usually because of your mitral valve. Okay? So let's get a new valve. Treat the underlying cause. Always treat the cause. That's why it's important to dig a little bit. You got to be a detective. What's pericardial tamponade? What does it sound like if you don't know?
It's fluid around the pericardium.
It's something that's pressing against the heart, correct? Now the heart can't squeeze. It likes to move, right?
Yep.
All of a sudden, your pericardial area is like, well, I'm going to expand. Your heart can only go so far. Oh no, now you've tamponaded your heart, so now your heart can't beat. Are you going to die?
Yep.
Probably. How do you think we would solve?
The needle, what's called, put a needle into your.
Probably going to do what's called a pericardial window, where we're going to go in
Pericardial centesis.
and we can do pericardial centesis, or we can do a window where we can go in and then release the fluid. But yeah, you're going to have to do something. That's calling your cardiovascular surgeon. They may be somewhere around. MI is huge. What's an MI? Okay, what's going on in the process?
Blood is getting starved from the heart.
Heart's dying. But you got to figure out where, right? You got to figure out what part of the heart is going. How do you do that? 12 lead EKG. You always do the EKG first, and then you call the cardiac team. Why do most ERs wait before they call the a code STEMI coming into the ER? Why do they usually wait until the patient gets there?
Because EMS is bumpy.
It's bumpy. So a large part of the times your EKG out in the field may have a lot of artifact in it, especially if the ambulance is trying to move and trying to get there. That's why usually ambulances stabilize first before they go. It's important. It's not necessarily you get there, you load, and then you treat in route, because sometimes your treatments are a little bit harder. Who's ever tried to start an IV in an ambulance? Not fun, is it? Especially if you're on some of the city roads or you're on a back road. You're not on even of a paved road. Really difficult to start. Anyone who's going to stay in the ER when they become a nurse? Okay. You may actually have to go on runs with your EMS crew to stay current in understanding what they have to do, because you have to give them orders. Yeah, go ahead. Try to start an IV when you're out in the wilderness and it's an unpaved road. It's not fun. Okay. What do you expect to see in someone who has cardiogenic shock?
Well, for early tachycardia, hypotension, narrow.
Correct. What's a narrow pulse pressure?
Different
Ooh.
on each side.
It's a narrow pulse pressure.
No, bound.
Jose's going to Google narrow pulse pressure. I know that's exactly what he was getting ready to do.
It's getting smaller. I don't know. I'm thinking it's getting brainy. It's tunneling down. That's what I just picture in my head. Something bad.
So you're picturing in your head that the pulse is...
I don't know, just
It's
really grounding. It's like JV.
Because when you have low blood pressure, your valve vessels
That's what I
are
was
full.
thinking.
What'd you find?
Pulse pressure is the difference between the systolic and diastolic blood pressure.
So your pulse pressure is the difference between your diastolic and your systolic. So sometimes you have some patients that's a distance away, right? So let's just say your systolic is 180 and your diastolic is 90. So what's your pulse pressure? What's the difference between 180 and 90? 90. Okay? But what happens is it narrows and narrows and narrows and gets down and gets down. And before you know it, your systolic and your diastolic are coming closer and closer together. Okay? Your patient is not doing well.
They're not perfusing at all.
You have no perfusion going on. Your systolic always changes. Fair to say? It's hardly ever the same number. Your diastolic usually is always about the same. You may have a 2 or a 4 difference in your diastolic, but it's usually pretty close. But your systolic can be all over the place. You can have different systolic pressure from one arm to the next. That's what you're thinking of.
Yes.
So yeah, you can have very different systolic pressures, especially if you have stenosis on one side or the other. Your systolics can be different, but your diastolic should be relatively the same. So a narrowing pulse pressure is someone who keeps coming together and coming together. This is when you go, oh crap. Because they will eventually, they stop because they're not perfusing anything at that point. Okay? Pallor, diaphoresis, delayed capillary refill time. What's normal refill time?
Less than 3 seconds.
Yep. If you got like 10 seconds going on there, you got something going on. Keep moving. Okay. Decreased cerebral perfusion. What does that lead to? If you get no blood up here, what do you look like? Confused. You're not going to mentate properly, right? I'm going to ask you questions and you are not going to know. Has anyone in this room ever been hypotensive? Okay, you weren't making much sense, were you?
No, I couldn't hear.
Your hearing was gone?
Completely gone.
Okay. Yeah, it's pretty scary when you're alert enough to know that your blood pressure is low, but you're not alert enough to really answer anyone's questions. You know something's wrong. That's a scary feeling. Okay? So, diagnostics for heart is actually pretty simple. Obviously, your heart labs, echo, EKG. Not hard to figure out. X-ray, I could care less about X-ray 9 times out of 10. The only thing the X-ray shows me that I care about as a nurse most of the time is the size of the heart. I can see the silhouette, and if I can see that the heart's enlarged, I can see someone has cardiomyopathy pretty quickly. But that's the only thing I care for on a chest X-ray, unless I'm looking specifically for the lungs. Okay. Obviously, what's your goal of treatment? Restore blood flow if you're having an MI. If you've got a clot someplace, it's actually trying to get in with stents. Hemodynamically, really decrease the workload on that heart. If I'm having an MI, guys, there's a reason why we want to really get them heart rate down, because I want to decrease that workload. Nitro, what does nitro do for you? Woo! Opens it up. Someone who has pulmonary hypertension, what drug do we typically put them on? It's not usually nitro. It's one of those things that you guys would never even guess. The original, huh?
Baby aspirin?
Not baby aspirin.
Is it lidocaine?
No, it's actually, for someone who has pulmonary hypertension, it's actually Viagra.
Oh yeah, that's right. That's why they found.
That was the original use of Viagra when it first came out, was pulmonary hypertension.
And
They found subsequently that it had some added benefits. So yeah, a lot of people will actually, some places, some pulmonologists don't use it anymore. They use another drug called Flolan if they need to, but that's just through IV pump. So they have to implant a pump on someone if they're going to do that. But yeah, you can actually give someone Viagra if they have, that will dilate where they need to actually dilate. But yeah, they added benefit. Beta blockers. Okay, balloon pump. If I really need to rest the heart and I want to control what's happening, it's the balloon pump. Dave is phenomenal because he is a heart-trained nurse. He does the balloon pump. I hated dealing with just the heart, so I never learned how to do the balloon pump. Okay. Hypovolemic. I say the word hypovolemic, you guys should automatically know, what am I missing? Volume. Volume of some kind. Is that volume blood? Is that volume just fluid in my intravascular space? It can be either, right? Okay. So, trauma patients, GI bleeders. If they're going to go into shock, it's going to be hypovolemic shock. Surgical patients, hypovolemic shock. Why do you guys think in all of your hospitals you have a mass transfusion protocol? It's for this reason, because of hemorrhage. Most all of you should know what your massive transfusion protocol entails, because it's a lot of blood real quick on a really sick person. The one spot you never want to have to call that for is in L&D, OB. If you call for mass transfusion protocol up there, you've got a mom who's actually bleeding, and they got to figure out how to stop it without trying to take the uterus.
It's like that lady that they
Yeah.
That was scary.
Here what's going on is fluid volume moves out of the vascular into the interstitial, right? We should not have volume sitting in your tissues. Would you agree? Where does volume belong? Vascular system. So if it leaks out and it's leaking into my interstitial, that's what's called third spacing. Who has seen these patients? They look like the Stay Puft Marshmallow Man, right? And the minute you touch them, their arms just like cave in, and you're like, ew, because their skin doesn't rebound. And then you touch them, and they ooze all over the place, and you're like, oh, this is so gross, right? You guys know what I'm talking about. You've seen these people. They're on your med-surg floor because they were in the ICU, and we third spaced them there because we gave them too much volume, and they can't pull it back into their vascular system, so they're out to here because their arms are too big to go like this. They're miserable patients. Miserable patients. One of the biggest things that you have to be careful with is with hypovolemic shock is you can give all of this fluid, but if it doesn't get into the vascular space, it does you no good. Okay? There's always a saying in the ICU or in the ER when someone comes in and they're extremely tachycardic and their blood pressure is low. They're fluid volumed deficit someplace. It doesn't do any good to start them on a pressor to bring their blood pressure up because their heart rate's already up, right? So typically you always want to be sure that the heart is filled first with fluid before you start pumping the heart even faster. Because the minute I start dopamine or I start Levophed because someone has no blood pressure, if my heart rate's already up, the only thing I'm going to do is increase my heart rate. There's no volume there to move around, right? So always be sure that you have volume in the correct space before you start going into pressors. This is something that the ER is notoriously bad at. I can tell you from working in the ER, we would always just be like, let's just start this. It's like, wait a minute, let's give some fluid first. Fluid, fluid, fluid. After so many liters, then you switch to your pressors. Cardiac output. You really can't assess cardiac output unless you have what's called a Swan-Ganz catheter in place to monitor cardiac output. But obviously, if I'm in shock, my cardiac output's probably pretty low, especially if I'm in hypovolemic. So, what are you going to look like? Increased heart rate. Eventually, you'll have an increased respiratory rate. If you do have, the only way you're going to know what your wedge pressure is or your stroke volume is if you have a swan in. And a lot of places don't do swans anymore. So.
But could you like a CVP?
You can get a CVP if you have a triple lumen in. Then you can get a CVP. If your CVP is really low, you don't have a whole lot of volume in there. Okay? They're anxious, they're confused, they're agitated. These are your patients that are trying to get out of bed because they have no friggin' clue what's going on. And then when I come around and I ask everybody, why is your patient in restraints? What are they doing? It's like, well, they're trying to get out of bed, but why? When patients are constantly trying to get out of bed, you got to figure out what the underlying cause of their agitation is. That's an agitation sign. Most people will stay in bed. Hell, if you offered me to stay in bed all the time, I'd be there. I'd be like, give me the remote, give me my phone, give me a pillow underneath my knees. I'll stay in bed. So if your patient constantly is trying to get up, unless they have dementia or something like that, try to figure out why, because there's a reason for it. Absent bowel sounds. Why do you think they'd have absent bowel sounds? They're shunting. Your gut will die with shock. Not uncommon. Sometimes you have to take it for the team, right?
My gut's already messed up. Go ahead.
There you go. Okay, goals of your treatment. Obviously, stop the fluid loss. If they're bleeding someplace, maybe you need to figure out where. Your trauma patients, these are the patients, no matter what, they're going to go to the OR. Especially if it's a stab wound, if it's a closed injury and we can't see. An exploratory laparotomy goes a long way. Open them up and take a look at what's inside. Especially if CT really doesn't show you all that much. We're not going to do an MRI because those take too long. What's the average time for an MRI? At least an hour. At least an hour. 45 minutes is the minimum time you're going to spend in MRI. So in an emergency, MRI is not what you want. I can get everything I need through CT scan. CT scan, 15 minutes, done. I got a belly scan. I see that there's blood, but I can't tell where it's coming from. Off to the OR I go. And there's another thing. Patients do not die in the OR. They will leave the OR very quickly and go to the ICU to let the patients die over there. Dying in the OR is a nightmare. It's a nightmare because the medical examiner may actually close off the room depending on what happened. That was not a fun phone call to make one day. Isotonic fluids. Why do we want to avoid LR? LR and saline are actually very similar. What's the difference between the two? Besides one's isotonic and the other is not. Please do not tell me that. What's the difference between saline and LR? There's only one component that's different. Potassium is in LR.
I was going to say something with an electrolyte.
It's an electrolyte issue. So that is the only reason why you guys, the only thing you can hang with blood is saline. You could technically hang LR. It would be perfectly fine. But the problem is it's got potassium in it. What does blood have in it? Potassium.
Yeah.
So your potassium level goes up the more units of blood you give somebody. You have to watch their potassium level, correct? Why do you think we give Lasix in between blood products on some patients? It's the potassium. We always give a loop diuretic that is potassium wasting. So then that way I can keep control of my potassium level. See? You guys didn't know that?
We knew it. We were just testing it.
That's the only reason why you avoid LR. I'm going to tell you your surgeons love LR. And the surgeons love LR because it's a better volume expander than saline is on its own. That's the other thing. They like albumin. Albumin is a blood product, but it actually is a big molecule, correct?
Mm-hmm.
Has anyone ever watched a nurse give albumin? It's a pain in the ass. Because it is so thick, it doesn't always drip in the chamber like it should. And so it's better if you put it on a pump because the pump forces it to come out. But you actually have to prime your tubing pretty good with a lot of albumin to get it to actually flow. So once you put albumin in, since it's a big molecule, what do you think water does? Follows it. Because it's like sodium, correct? Water follows sodium.
Yeah.
So if I can shift my sodium in my K, and if I don't have anything in my intravascular space, and I can get some sodium in there, water is sure to follow. The K will come out because sometimes if you are dehydrated, your K may be high. Okay? So if I increase my volume intravascularly, sodium will come in, the K is going to come out and go where it needs to go, and then I'll eventually stabilize. The things you didn't realize you needed to know about your labs, right? It isn't just a matter of knowing what the normals is. It's like, how do you get them to shift? I like to ask med-surg nurses all the time when I'm rounding in the hospital. I like to ask them, what's your K level? And they're like, oh, it's 3.5. What are you doing about it? Oh, we're just giving him a K rider. Thought about asking for POK? No. Why not? I don't know.
It's a big pill.
So they're like, well, why would I want POK? Well, can your patient eat? Oh, yeah, they can eat. So what's better for our patient? Potassium orally or potassium IV?
Potassium orally because you're only getting potassium.
Because potassium's better absorbed in the gut. than it is IV. It actually will come out of your vascular system really quick. So if you have a patient who's having a hard time keeping their K up, ask for it PO. Do PO and IV, and you'll actually stabilize out. Okay, neurogenic, this is actually pretty easy. Neurogenic, what's in shock?
Fine.
The brain or the spinal cord. Nervous system of some kind. Okay? Hypotension, bradycardia, paralysis. Okay? I mean, think about it. Anyone work down in the ED and seeing your spinal cord injury patients come through? They're not fun, are they? It's not pretty. When you have massive head injury, you can have neurogenic shock. Okay? The only thing that we absolutely do MRI for immediately and we bypass CT is if we're looking for cord compression. Cord compression of the spinal column cannot be identified on CT scanner. So some places your MRI people are only on call after a certain time. The only people who can usually get MRI there immediately is a neurosurgeon, and it's because he's looking for cord compression. If that's what I'm ruling out, I absolutely must have MRI because I can't see the cord. I can't see the ligaments of the cord very well on CT scan. I need that soft tissue read. So MRI is better for soft tissue. CT is better for bony prominences. So that's why ortho loves CT, because they can do reconstruction and they can remodel a hip. They'll do an MRI to look and see if anything's wrong, but when they'll actually want to do a CT so they can remodel what it's supposed to look like after they refix it. Okay? First, skin is warm and then it's cold, but it's always dry. Neurogenic shock, regulating your body temperature is really difficult. Okay, but they're usually not diaphoretic. Here's really, you have to know if you're dealing with a head injury or your spine. If it's a spine issue, there is debate still in medicine. We're going away from using high-dose corticosteroids to prevent further damage. Some physicians, some neurosurgeons will still put people on like a Decadon drip or something like that, but there's no evidence that actually supports that high-dose steroids do anything for spinal cord injury. If anything, we put people on really high-dose steroids like that, okay, we're sending the body into a different form of shock when we're constantly keeping the blood sugar so elevated. Because all that steroid is doing is breaking down into sugar. We're going to have blood sugar issues. That's why when you have COPD patients and you do their blood sugar, if they're on steroids, the blood sugars are all over the place. Watch when you check their blood sugar. If they've just taken their inhaler medication or they've just had their prednisone and it's been about an hour, it's probably not a good time to check their blood sugar. It's actually going to be elevated. Hypotension. So when you use pressors for neurogenic shock, this you definitely have to be careful with. It's not a fluid-related issue, so yes, we're going to start them immediately. We're usually not going to use dopamine because we need something that's really going to do perfusion of everything. So you should start them on Levofed immediately. The old saying, Levofed, leave them dead. The Midwest drives me insane compared to the coasts. If you work on the coast, they actually do more modern medicine than the Midwest does. The Midwest is always a little, we're sleepy towns. We do medicine the old way. You have old-time doctors who still perform the same way they did 30 years ago when they came out of med school, and you're like, oh, why? When you come from someplace, coming from the West Coast, we don't use dopamine anymore. It is not a first-line drug for hypotension because we know all it's going to do is increase my heart rate. And the last thing I really want to do is increase someone's heart rate when I'm trying to get them but I'm trying to decrease the oxygen demand, but I want to increase their blood pressure, well, giving them dopamine isn't going to do me any good. So we use Levophed more often than anything. So neurogenic patients, you're probably not going to, if they're bradycardic, you're going to give them atropine, but if I need to treat hypotension, I'm going to go with a more aggressive form. Dopamine's not going to be it. Dobutamine, we use with cardiogenic shock because that's a squeezing issue, right? I may not be able to pump very well. Dobutamine helps me to pump. Doesn't really do much for raising my blood pressure unless it's pumping. So if you know you have a mechanical issue with your heart, dobutamine is the drug of choice for that. But if my pumping mechanism is fine, dobutamine's not going to help me. This should be simple. Everybody should know anaphylactic shock. What's going on in anaphylaxis?
Allergic reaction.
It's the last form of allergic reaction, right?
Yep.
It's the most severe form to an allergic reaction. What is closing? What's going on? Airway. Pulmonary. I am going to die because I am not breathing. All right, so what's the drug of choice? Epi. This is why we have EpiPens, right? Okay, so now I'm a new patient. I'm now allergic. I'm 44 years old because I just turned 44. For the first time in my life, I'm allergic to peanuts. And now you got to give me patient education. It's up to you to teach me how to use my EpiPen.
Right in the neck.
The thigh.
Thigh.
And the thigh.
Thigh is the best spot. But then what do? Okay, so I gave myself my EpiPen.
Go to
I'm
the
done.
emergency room.
You just call
Call
911.
anyone.
Why do I have to call 911? Didn't I
It'll
just
come
treat
back.
myself?
It'll come back. It's only temporary.
Oh, it's going to wear off. Oh, I didn't realize that. How long does it take Epi to usually wear off if you give it intramuscularly through the EpiPen?
30 minutes right there. Yeah.
You have about a 30-minute window. So you might want to give it and call 911 and get them there. Because by the time you get to the emergency room, you are going to need another dose. By then, we're going to give you your Epi IV for anaphylaxis. We're going to give you a few doses. We may give you sub-Q, but we're definitely going to start an Epi drip until, depending on how bad you are, until we get symptoms under control. Okay, but yes, it wears off very quickly. So be sure your patients understand that. I've had plenty of patients who have done 2 or 3 EpiPens before they came in. Well, that's a lot of EpiPens to go through. Those things are expensive.
I think like $300 a pop or something.
Yeah. So people, be sure you do proper education, especially if you're the emergency room nurse and you're discharging somebody. The other thing is, how often should they check to be sure that their medication is still...
Once a month, maybe at least.
Usually when your pharmacy fills it, they're good for about a year. You need to look at the expiration date. Now, what are some patients starting to do?
Use expired Epi because it's so expensive.
Got it. You got it.
It's
Now,
not that strong.
let's think about it. Just because it expires today, it's Valentine's Day, so my Epi is now going to expire because it doesn't love me anymore. Do you honestly think that the medication is no longer effective?
It's just not as effective because they have like or whatever.
You sure about that though?
But at pharma, I think pharma's
So do you
the
think-
best person.
Why do we have an expiration date on it? Who tells us we must have an expiration date on everything? The FDA. So yeah, it doesn't necessarily expire. Because if you go turn that EpiPen back in and get a new prescription, what do you think we do with all of our expired medications? Where do we send them to?
China.
We send them to underdeveloped countries.
Yep.
We send them on mission trips. Think about it. Who's ever gone on a mission trip? Okay?
Already wants to.
We took
I wanted to.
expired
Facilitate that
equipment
for
and
us.
You took expired equipment and medication. Where did you go?
To the Dominican Republic.
Dominican Republic. They accepted you, open arms. They love to have us.
Believe that. Oh my gosh.
You didn't even think about that, did you? No. We're happy to change for us to change in our medications. The only reason there's an expiration date is because the FDA says it can only be on the shelves for so long. So every pharmacy, every over-the-counter drug, everything we pull off, they save it. They don't get rid of it And then they find out someone's going on a mission trip. Brittany goes running around the town. She goes, I'm going to go to every pharmacy in Kenosha. I'm going on this. It's a write-off for all of the institutions.
So then milk really doesn't expire?
Oh, milk expires. Do not drink
Asking
it.
for a friend.
Yeah.
Are you actually, like, let's say you have a family who is really struggling with financial, and are you allowed to tell them that, hey, your EpiPen is just fine?
So you're a home health nurse, and you know your patients aren't going to be able to fill their EpiPen because it's expensive and they don't have insurance.
That's your license.
You just tell them that you have a friend going on a mission trip that has a bunch of epi.
It's hard. I'm not going to lie to you guys. Right now in nursing, we're sort of at a struggle because we know patients can't afford stuff, right? We know. I mean, hell, half of us probably can't afford to go to the doctor with our own insurance.
Eliquis is like $800 a month. Like, that's just insane.
Right. So what do? What you honestly do is you tell your patient, technically, your med is expired. I understand that things may be difficult right now. Chances are, if you have a situation and you still have this medication and you need to use it, I would go ahead and use it, but still call 911 and get help. You're better off having them use the medication than them not. But you start with the caveat, you just say, hey, look, technically it's expired. Now, if you have medication sitting around for 4, 5, 6 years, you might want to throw it away. But I'm telling you, if I've got a prescription for Zofran sitting at home and I'm a little nauseated, I'm still going to use it. Does it work? It absolutely does.
One is like over a year old.
But I get the ethical dilemma that you're facing. So you take the liability away. Technically, it's still good, especially if it's the day after. If it's a year after, yeah. But all of our medications we send to third world countries. Any hospital supply, your IV tubing, guys, does it truly expire?
No.
I mean, come on. But okay, there's an expiration date on it, right?
Because they can only guarantee it for this long.
They only guarantee it to work effectively for that long.
Doesn't mean it won't work.
Correct. But the FDA is the one who regulates all of that
Just
stuff.
like makeup and stuff.
Like, do you think those people on the mission trips, when you leave and they're looking, they're like, wait, what the?
You know what?
They don't care.
Brittany it just dawned on her.
I cannot believe that.
It just dawned on her. A lot of people probably don't realize that they're taking a lot of the expired stuff out of the hospital. Why do you think, those of you that are aides, I know because I had to do this, when it's really slow, someone gets the list. Can you go check to be sure? Jaco's coming. Oh, we need to be sure that everything that's in the patient rooms is not expired. Yes. Believe it or not.
I always call off the first of the month.
You don't want to do
I
inventory?
already know.
Nope. Okay.
Night shift today.
Obviously, with anaphylaxis, your goal is to obviously get them some epinephrine. Oh, what else do we give them besides epi? Benadryl? What else? Huh? Solumedrol. What else can we give?
Decadrone.
Pepsid.
Oh.
Your ER people are like, oh, that's right. I always see them give 20 of Pepsid IV. Why do we give 20 of Pepsid IV? What is Pepsid? Trish, you're going to look up Pepsid.
Well, it's an antacid for the stuff.
I know, but what does it block?
Oh, the histamine. It's a H2 receptor.
Yes! Why do we give it to someone who's having an allergic reaction?
They're having a histamine.
Because they have a histamine response. Pepsid. So your GERD medications, Xanax. Oh, Xanax. Xanax.
Yeah, Xanax. Woo. That's cool.
Xanax bars are $8.
Yeah. So any of those that you can get over the counter, be sure your patients have those in the house if they have an allergic reaction. If they are allergic to something, ask them. Yes?
Can you say again why you would give Pepsid?
Pepsid because it's an H2 blocker.
And H2 is just the histamine?
It's a histamine. It blocks your histamine.
Okay.
So it's going to stop the allergic response. So Benadryl, Pepsid, your Epi, okay?
So Epi, Benny,
Epi, Benny.
and Peppy.
Yep, and we do give steroids, obviously, Solumedrol. Open up the airway. Okay? If it's a reactive airway, we want to calm it down a little bit. So yeah, you're always going to do the steroids. But yeah, you guys forget the Pepsid. Next time, those of you that work in the ER and your allergic reaction comes through, please watch the medications your nurses give.
Got you. I won't let you down.
I know. And then bronchodilators.
Yeah.
Buterol. What else can we put?
Action. I'm just
How else can we give Epi?
rack Epi. Receiving.
We can put Epi into the breathing treatment.
Nice.
So give a nebulizer treatment, have them breathe in some of the Epi. ER docs are famous for doing this. They'll give Epi a couple of ways to be sure that it gets into where it needs to go. So don't be surprised if your RTs are giving a breathing treatment with a nebulizer and there's Epi in that breathing treatment. Okay? Airway. It's the most important thing. Okay, take a break. Our plan will be, because Dave said that you guys don't have any assessments for 449, right? You don't have any tests to take today.
Yeah, that's next week.
Oh, well, that's too bad.
Supposedly.
It's everywhere. This is a huge CMS issue right now. Who is CMS? I say CMS, you guys think of,
What are you talking about?
Yeah.
You know?
what's the definition of CMS? Who's CMS?
Certified medical.
How about the Center for Medicaid and Medicare Services?
Okay.
Oh, you guys don't know who CMS is?
No.
They're the ones who dictate everything in the hospital. Reimbursement.
Oh.
Whatever Medicare reimburses, private insurance reimburses. So yes, it's called, in hospital lingo, we shorten everything, correct? So Center for Medicare and Medicaid Services gets shortened to CMS. When someone says CMS is coming through, please panic. Because if CMS is coming through, something drastic happened at your hospital and they have said JACO cannot come in and do the survey, they're coming in. They allowed JACO to come in and do your site surveys every 2 years and deem you to be accredited. And they'll continue paying for Medicare patients to be there. But if you have a Medicare infraction, they'll pull your Medicare dollars from you.
How is this system functioning?
This is a for-profit facility. So they function a little bit differently than your standardized hospitals do. But they get their reimbursement because I think 75% of their payer mix is from as Medicare.
Yeah.
You have to know who your payer mix is. That's what leadership class is all about, is understanding how the back end of the hospital operates. Because you guys have to know. You have to know. All right. Sepsis, systematic inflammatory response to infection. It's complicated by organ dysfunction. Doesn't always happen. Sepsis just basically says you have an inflammatory process going on, right? You had surgery. I just removed your gallbladder. Your temp is 104. I expect certain things to happen. I expect you to have this response going on. The problem comes is when your body never corrects this and you never get out of it. I took your gallbladder out. I didn't give you any antibiotics. You're septic. Okay, what am I going to do? There's different forms of sepsis. It goes from being nothing to just being in what's called SIRS, which is systematic inflammatory response, all the way to septic shock. Okay? The goal is to treat it here. Is to treat it here because it's septic shock. The likelihood that you're going to survive is not that great. Okay? The more organs that are involved, the higher your mortality. Okay? So here, what's going on is your pathophysiologic effects, vasodilation, then eventually your blood flow is going to get disturbed, and then you'll get myocardial depression. Eventually, your heart will give out. The body cannot distinguish which organ's more important, the heart or the brain. A neurosurgeon will tell you the brain's more important. A cardiothoracic surgeon's going to say the heart's more important. The body doesn't know which one's more important, so it protects both of them. So how does it protect the brain? If I'm going into septic shock, how do I protect the brain?
More blood.
I actually decrease my blood flow because I want to decrease my oxygen demand, decrease my glucose demand up here. So when people go into, when we do CPR on somebody because they've had an MI and it was a witness arrest and we do hypothermic protocol, why do you think we're cooling them all the way down?
Decreases demand.
Decreases demand. I'm actually trying to protect the brain. That's why we send people into hypothermic protocol. And we get them down to a core temperature, guys, believe it or not, of 32 degrees Celsius. That's cold. That is cold. And you cannot be cold and dead.
You have to be warm.
You have to be warm. So that is why we keep them cool for 24 hours, and then we start the rewarming process. Rewarming phase is actually the worst of the phases. When we rewarm somebody that's in the ICU, you can kill them if you rewarm them too quickly. I drop that temperature greatly. I drop it fast, but I rewarm slowly. So when you guys are doing your blood pressures and you're trying to titrate blood pressure medication, titrate up quickly because I'm hypotensive. I want to get my blood pressure up. So you increase those drugs quickly. But once I stabilize, I come down slowly. ER sucks at this. ER nurses throw these drugs on, and they're like, oh, I have a blood pressure, it's 120/80, I'm going to turn this off. Like, no!
Wrap it up, boy.
Just leave it there for a little bit. So some things to be careful of with septic shock. You can have a temperature that's either up or down. You cannot have both. I got on some students that I teach in the LPN program, and when they select all that apply, and on one of their questions, half the group told me that the patient would be hypothermic and have a fever. You cannot have both at the same time. It's one or the other, right? Okay? EF, what does EF stand for? What's a normal ejection fracture? A greater than 55. Okay? It's not going to be 100%. I don't think I've ever seen someone above 75%. Usually it's a greater than 60. Okay? So the more I'm pumping, the better off my heart is. It's happy, right? What's hypoxemia? You guys are already going through respiratory. Please tell me you know what hypoxemia is versus hypoxia. There's a difference.
Tissue is not getting enough oxygen.
Hypoxemia is tissue.
Tissue?
Yeah.
It's tissue.
Anemia is tissue.
Right. That's all you guys have to keep straight. If you don't try to memorize the whole big word, just look at the back end of the word and loop it to something and you're good. Emia is tissue. Hypoxic, if I'm hypoxic, I'm just not getting enough, my O2 sats are low, right? Hypoxemia is your tissues are actually losing oxygen. There's a big difference, okay? Respiratory failure is common 85% of the time. They're in hyperventilation. You guys just went through a whole thing on discussing ARDS and what that looks like and what it does to the lungs, right? Mm-hmm. Talked about ventilator management and all of that good stuff. Those are difficult patients to take care of. If you have a septic shock patient and you get into respiratory failure, you're screwed. Respiratory is the hardest organ to come back. Kidneys are the easiest. Respiratory and lungs is the hardest. You may end up with very permanent damage in the lungs. You never want someone to get to ARDS. Long period of time, septic shock patients, 40% of them go into ARDS. That number's probably a little bit higher right now. ARDS is huge. Your lungs get so damn stiff that I blow a lung because I put too much pressure in. So once I do that, what do I have to do?
Chest tube.
Chest tube, but what do I do to the ventilator?
Decrease the volume.
Drop the PEEP. Why am I dropping PEEP?
It takes too much pressure.
Because PEEP, first off, your body has its own internal PEEP. Does it not? Okay, so if you're breathing a little bit over that vent and I'm trying to give you so much pressure, your lungs can't expand to the pressure I'm asking it to expand to. And that PEEP is positive end expiratory pressure. So at the very end, how much volume am I pushing out at the end? Well, if you can't push, and I got you on a PEEP of 20, and your lungs are like, I can't do that, they're going to blow. And then we turn it down to like 5. Okay, that's why your respiratory therapists are so valuable. They know all of that. All you'll do is you look at them and you're like, oh crap. I can tell by the ventilator I'm not perfusing. Okay? Crackles. Warm, flushed to cool and mottled. Mottled is a late sign of someone in septic shock. Mottled.
Normally it's you popping up on the screen.
Do you guys see me pop up on the screens?
Always. Oh yeah. Especially in community, we always like every day like clockwork. Why'd you have to go off screen, huh?
It's just easier to. Mottled. So I always think of, I'm going to hold up your backpack for just a second. This color. Think of it and then add a blue into it. That's mottled skin.
The purple or the brown?
The purple.
Okay. So I'm seeing brown.
Oh, are you colorblind?
No.
Oh, okay. Oh, the back. It's the purple.
I know. I was like, wow, that's pretty impressive. Wow. I was like, what? Yeah. I'm glad you said it too.
So like the color of your shirt.
Yeah.
Yeah.
Oh wow.
Put the skin.
It's not pretty.
We get a lot of hospice patients in the color,
So when someone's mottled, have you ever been someplace where your hands or your feet got really cold because you were out, and then all of a sudden, as you come inside and it starts to warm up, you turn into like that purplish? That's mottled. So when you've got someone who's in shock, when you have that going on, that's the shunting of blood. It's going into one area, and so usually you're going to have your chest is going to get mottled, and it starts to creep up and creep up and creep up and creep up, and then all of a sudden you turn cyanotic. All right. Hopefully, they're all in New Orleans right now. Dave's there. He was gambling at the casino.
Before accepting his award, of course.
I think he gets his award tonight.
Very nice. Is it gonna be a big book bag?
I don't know.
Is Casey down there?
No. I don't think so. Because Jessica's down there as well. She won the System-Wide Innovation Award. So she went as well. Okay. What do I do with my clicker? There it is. Agitation. What's paralytic, Elias?
Like it's sound?
Everything just slows down, right? Get an Elias. Eventually you'll end up with a Bowel obstruction. That patient's eventually going to go to the OR because a bowel obstruction is usually has to be dealt with surgically. All right. Diagnostics. Whenever we say diagnostics, guys, you should automatically think of x-rays and labs. Those are diagnostic procedures. X-rays of any kind. I don't care if it's chest x-ray. I don't care if it's a CT scan. X-ray. And then your labs. Labs are always first. They're the quickest to come back. Okay? So the only time labs take a long time to come back is if you're looking for something very obscure. Those labs aren't always drawn, but your CBCs come back quickly. Your troponin can take about 45 minutes to come back. So your cardiac enzymes, although we do them quick in the ED, sometimes they can take a while. Your chemistry panel should take about a half hour, 45 minutes as well. Unless, of course, you've got something really going on and you have to spin it down even further and keep spinning and keep spinning. Sometimes the lab will call you and they'll be like, we still have to spin this down more because it's not giving them a value. So it can't give you a value, okay? Glucose, those are quick, right? We do those on the units all the time. If it's high, then what do? You got to draw a lab, right? Okay? Blood cultures. This is imperative. How many of your facilities allow the nurses to draw the blood culture still? Probably only in the ED. And you're probably not supposed to do it, it's just no one's really slapped your guys' hand.
No, they like actually make us do like sterile procedures, sterile gloves, wear a mask, everybody in the room's wearing a mask.
So do you guys absolutely know that blood cultures, those results are actually scrutinized because we can tell if it's a false positive. If it's a false positive, do you know why?
Because somebody rubbed their hands.
Skin cells are on it because the people didn't clean the skin appropriately before they did the blood culture. So blood cultures are actually, those reports are pulled. The ED is the worst offenders because we put it in an IV so quickly, and then they say, oh, 2 sets of blood cultures, and you draw it from the first IV you put in. Well, if you don't draw it at the time you initially put that IV in immediately, but you didn't prep the skin correctly, you'll have a lot of false positives. So a lot of hospitals say, absolutely not. Nurses can't do it. It must be the lab techs who do it. So know your hospital's policy on blood cultures. Okay? Sometimes you can, sometimes you can't. Decreased platelets. Why do I care about the fact that my platelets are down?
Clotting factors.
Clotting factors. I'm going to go into what?
DIC.
DIC.
Death is pain.
Disseminated intravascular coagulation. I get there with septic shock. I'm toast. So you always want to keep an eye on what your platelets look like. Lactic acid.
Yep.
The first lab we do for sepsis.
Lactic acid.
Lactic acid.
Quick.
If it's elevated, I'm going to give you some fluid. I know that there's something going on. Something to keep an eye on, pay attention to. Obviously, the goal, it's fluid replacement. You may think 6 to 10 liters sounds like a lot of liters, but when you're down 3 liters already, okay, well that 6 to 10 just became 3 to 7. It's not a whole lot. Be sure you always replace, and we're always going to put you on an isotonic. Or we can add albumin in there. For the first 6 hours, you have to put in a triple lumen on these patients. We need to know what the CVP is. I want to know what my vascular system looks like. It's easy to do. You can do a CVP off of a PICC line if the PICC line is in the proper location. It's not ideal, but you can do it. You just do it off the blue port. But you can do it off a PICC line. You only do vasopressors once fluid has been replaced. You want to increase your blood pressure, but you want to decrease your stroke volume. What's your stroke volume tell you? Stroke volume tells you how hard your heart is pumping, right? Okay? Well, I don't want it going like this. I want it to be nice and smooth, correct? I want it to be nice, steady. In order to get I don't need my stroke volume sky high. I need my blood pressure to increase. Because if my blood pressure increases, if I have fluid in the system, the stroke volume will be enough to push it out. And it will actually decrease the stroke volume because there's no resistance. Okay? Broad spectrum antibiotics until the cultures come back. What is the one antibiotic that you can think of that a lot of sepsis patients are actually started on? Banco's one of them. What's another one? What's one step above Banco? Zyvox.
Yeah.
Zyvox is used a lot in septic shock. Huge broad spectrum. There's a big issue with Zyvox.
It's hard on something.
It's hard on the wallet book.
Oh.
Zyvox is still, it averages about $1,500 for a 7-day course. That's the PO.
Mine lowered.
You should see the price of TPN. You're good.
That's why Zyvox is not usually prescribed for patients when they go home. Because even a 7-day course of PO, just the pill, is about $1,500. So can you imagine what the IV portion costs? And you're getting it once a day in the hospital. Now imagine you send someone home. That's why we like Vanco, because Vanco is inexpensive. I can get Vanco prescribed all day long. Okay? Zyvox, on the other hand, I have to get prior approval for insurance before I send someone home if they still need Zyvox. So I med-surg floors, it's difficult for them. You go around and you're like, why the hell is this patient still here? Oh, well, they need this, or they need Eliquis, or they need Coumadin, or well, they need Lovenox injections because they're an ortho patient and they just had ortho surgery and they still need 2 weeks of Lovenox injections. All that has to be approved. Do you know Lovenox is still expensive to get?
Yep. Same, because we give it all the time.
You have to get stuff like that approved. So this is what case managers are for. Case managers have to have a bachelor's degree in order to work because they have to understand community resources. They want them to have a community class. But all of that plays into how you get the patients the hell out of the hospital. And we're kicking them out so much sooner than we ever used to. Patients that you have on the med-surg floor there, Jose, that you're taking care of down on the 2500 wing, that they're just heavy as, you're just like, God, I can't believe I'm down here again. Those patients 10 years ago were ICU patients. But now we're putting them on the med-surg floor. You're putting someone with a lactic acid of 4 who really doesn't have too many other issues right now. They're going out on the med-surg floor and they're hoping that we'll catch them with a sepsis screening. Shit, it used to be when your lactic acid was elevated, we sent you down to the ICU for someone to keep an eye on you closer.
My guy done 2300 during clinical had a 3.3 hemoglobin.
Yeah, oh yeah, that was fun.
Remember that guy?
Uh-huh.
3.3.
Yep.
Mhm.
He went down to the IMC.
Yeah, he went up to the IMCU real quick.
It's all about trending, Nick.
You need to have the data, right?
I only get 12 patients to watch, so it's okay.
Huh?
I only get 12 patients to watch, it's okay.
It's okay. On night shift, because there's only one down each hall.
Yep.
Over at St. Cat's. They're increasing that core. They're trying to increase it. But it takes time. The other thing is, this is what we didn't used to do before. Stress, ulcer prevention. What do you give every hospitalized patient now? You got it. Which is the one we use? Protonics. What do we give everyone in the hospital that's an inpatient now? Everybody. Protonics, the life-saving drug. People laugh about it. Nurses laugh about giving the Protonics. Everyone gets Protonics simply because we do stress ulcer prevention on everybody now. It's almost like DVT prevention, right? You admit a patient into the hospital, what do? It's now part of the order set. Protonics, either once a day or twice a day, and either Lovenox, heparin sub-Q, your SCDs, your TED hose, right? Don't want them getting a clot. We figured out some things over the years. We pulled enough charts and we learned. People who are in the hospital are under stress, are they not? What are some things that people in the hospital, I don't care if they're just there for something simple, what are some of the things they're worried about?
Money, family.
Money.
jobs.
The first thing they're worried about is how the hell am I going to pay for this?
They said drugs.
They're worried about their job.
They're worried about their jobs. Some people don't have sick time. They don't show up to work. They don't have a job. We don't live in a society anymore like we did back in the 80s. Back in the 80s, who grew up in the 80s? Who was with me in the 80s? Oh, good God.
No, joined in the 90s.
Okay.
92.
In the 80s, you hardly ever went to the hospital. Your parents didn't take you to the emergency room because health insurance wasn't as available even in the workplace. It became more and more of a perk of having a job. Unless you had your own private health insurance, it didn't cover a whole lot. So your parents waited and took you to the doctor when the doctor had an opening. ERs weren't as impacted as they are now because people didn't take the ambulance all the time because they couldn't afford it. Back in the 80s, things were kind of tight. There were recessions that people were going through coming out of the 70s and the early 80s. I can remember very rarely going to the hospital. It was mostly going to the doctors. But the doctors have the availability to see you.
Not anymore.
Not anymore, because they're too overloaded now. So now what does everyone do? They go to the emergency room. Right? What else are they going to do? Okay. Management. When you're answering NCLEX questions, a few things to think about. Assessing always first. Airway. If you have to assess 2 different bodily areas, and airway is one of your choices, please assess the airway before you assess the lungs. Because lungs is breathing, airway's different, right? So always assess the airway first, then assess your breathing status, then assess your circulatory. Now, the only reason in BLS we have gotten away from doing ABC and we now do CBA is why? Why the flip?
Because they've proven that if you start compression sooner, the quicker they are.
Air, oxygen in your bloodstream.
Who was it geared towards of why we flipped? Was it healthcare providers?
No.
It was the community, right? Because what we found was when the American Heart Association actually started doing surveys with people in the community, people were afraid of doing breathing for a patient. So what they said was we would at least want you to start chest compressions because there should be enough oxygen in the patient's body to circulate if you're doing good effective chest compressions. So that's why in BLS now it's CBA. But when you're answering NCLEX, you answer airway first because you are a healthcare provider.
Yeah.
It will trip you up. People think about it, they're like, oh, but okay, yes. In CPR land, when you're doing CPR, that's more for the outside. When you're in the hospital and you're thinking like a nurse, which is what you have to do, and when you're answering NCLEX, is think like a nurse. Always stabilize the airway first. Then you're going to restore perfusion. Isotonic, hypertonic, we do not use. Hespan, albumin, dextran. Hespan is, or Hextant is what it can also be called. It's a volume expander. So trauma docs love to use this. They want to get as much volume as they possibly can intravascularly quickly. It is a nice fluid. It's not like albumin, but it's a starch. It's got some starches in it. Starches are big molecules. Where there's a big molecule, water will follow because water is small. So give you some Hextant, get it into your system, pull some fluid in there, get you to the OR. It just gives me time. Albumin, in most places, it depends on your hospital. It is a blood product. So sometimes you have to get albumin from the blood bank, or sometimes pharmacy has it. It just depends on how your hospital carries it. So you just have to know where it comes from. But if the lab carries it, then you just know you have to get it. You get it like blood, and you check it out like blood. Do, 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 do. Do, do. Oh, the one thing that we were, careful there. The one thing we were bad at, I was going to say a different word, when I started nursing was nutrition. You know, when I started almost 18 years ago, we did not feed people right away. Now it's one of the first things you guys do. It's like you start all of this stuff, and you automatically have an order to put an NG tube down if they're intubated, and you're going to start feeding the gut immediately, unless you have something else going on with the gut. If you can't do that, you start TPN. Do you know we used to wait like a week or more before we started feeding people? That was at the same time where we left patients in bed and never got them out. So what do you think they always had?
Pressure ulcers.
Pneumonia. We'd be like, post-op patients, don't move. Now, you have a patient who's just had a cabbage, they're up in 4 hours, at least sitting in a chair. We didn't used to do that. It was unheard of to have someone who just had a coronary bypass surgery to get out of bed under 5 days. It was like the first week they actually laid in bed and they didn't do anything. And we wondered why they all got pneumonia. What do we know now? Staying in a dependent position causes your lungs to not work and you get pneumonia quicker, right? So now you get every surgical patient up. You're the stellar tech that's down the surgical wing, and you're like, we're walking. You don't give patients a choice. You just say, oh no, I got to go on my walking rounds. I got to get my steps in, so you got to come with me. Patients now know they have to get up. We didn't used to do that. Daily weight. Can we weigh patients?
Yes.
Absolutely. If you do it correctly. ICU nurses, you suck at this.
I know.
Hit the bed.
Because you forget what you zeroed the bed with. There should be a standard protocol of what you zeroed the bed with.
Or they take it to the OR and then somehow it adds 5,200 pounds.
Yep, because they re-zeroed is what probably happened. Someone accidentally hit the wrong button and they re-zeroed the bed with everything on it. So you have to, most ICUs have a standard of what can be on the bed to zero the bed with. Your patient gets into the bed, you weigh the patient. You never zero the bed again until the next patient. Because when you do that, you've screwed up your patient's weights. And when you want to see a trend, you can actually pull it from the bed if you have the proper beds. So be sure you weigh your patients correctly. Okay? You have to know it's usually one fitted sheet, one flat sheet, and one bed spread, and one pillow. ICU, you have 20 pillows on your bed, and your patient's been cold, so you have 3 bed spreads, plus you have 4 warm blankets on, and you left the SCD machine hanging on the end of the bed. The frame weighs. So anything that's hanging on the bed is going to weigh with the bed. So you have to remove the SCD machine. People forget that. Daily weights. Obviously, electrolytes, protein, and albumin. Okay. Let's see what this next one's about. This one's actually pretty, if you guys going through the first one that Dave went through, this is actually pretty straightforward stuff. So he always starts with part 2, and then he goes back to part 1. So since he's already started with 2, and you already understand the blood flow of the heart, goodbye. Okay. Risk factors for an MI. Smoking. Obesity. Diabetes. Being a man. Yes. Drugs.
High cholesterol.
High cholesterol.
Also being a woman.
Sedentary.
Stress.
An older woman.
Postmenopausal women. Young women usually not. They're not at risk. What are young women more at risk for? Blood clots. Why? Birth control. Absolutely. And you. The only reason you're at risk with birth control is because you probably do what? Smoke. The smoking increases the risk of blood clots with the with the hormones that are in birth control. That is why you actually now see a lot of OB docs won't give you birth control, or they give you a very low dose birth control if you smoke. It's a huge risk. Metabolic disorders. Someone said drugs, cocaine and methamphetamines.
Because cocaine is the word, right?
You get an ICU patient.
It actually can ruin your bowels.
You get an ICU patient that did 5 lines of coke, and you wonder why they had chest pain.
Their troponins like 34.
Yep. Sedentary lifestyle, stress. Who in America does not have stress right now?
Who in nursing school?
Not us. Yeah.
Not us.
I don't know. Jeff Hill just gave me a really cool stethoscope, so I'm not stressed about it anymore.
That really solved everything.
Yeah.
That solved everything.
So did
You know
Jason.
what? This is what I'm more worried about than anything, especially with our younger population. Teenagers. How many of you know teenagers that suffer from so much anxiety and stress? We see them come in the ER all the time, do we not? If you work in a community care area or you deal with kids who have mental health issues, this increases, does it not?
Uh-huh.
Kids have to do active shooter drills nowadays. Like, my coworker has an 8-year-old who has anxiety problems because of it.
Right. Okay, those of us that lived in the 80s and the 90s.
And today.
What did I do? What did I
On a
do?
radio station.
Oh, Snapdragon Pop.
You turn your computer off?
Oh.
No, my computer just died.
Oh, I thought you were trying to take it off the screen so we couldn't.
No, this one won't work in my... I forget that my computer doesn't have a very long battery.
Is there a tissue box up here? Oh no, it's right behind me. Never mind. Sorry. Thanks for my liquid.
How are you? I'm good.
Did you hear about your
I'm like, what the hell happened here?
I'm so sorry, Jose.
Active shooter. I mean, shoot. I grew up in the 80s. You didn't know anything about kids getting shot in schools.
Not till the 90s.
It was like,
Generation, what is it? After
they
what?
deal with different stressors now. I mean, each generation deals with their own things, right? But okay, I'm sorry, but if I'm a school-age kid, and I have to be careful that someone may come into my school and shoot at me, what's the other issue that's really prolific in schools?
Suicide.
Bullying. I'm not going to say that bullying wasn't something that we stressed upon when we were in school. Think about when you guys were in elementary school. Did you worry about bullying?
I was
I
just
was
not
bullied,
like
so.
Was it something that was like out in the open for you guys?
Oh yeah, everybody got bullied, even the pretty ones.
Everybody did. But I think we looked at it differently.
But we didn't have social media either.
Oh, that is
Correct. So that's probably our bigger issue more than anything is social media. Because now what can the bullies do? They hide. They're behind a keyboard. They're behind a cell phone. I don't know who's coming after me. Do you guys realize how many fake accounts people have?
Well, Catfish showed me that.
Who did?
Catfish. It's a show about like
people
an
send
older
some weird
person.
stuff to people they don't know.
Okay.
I actually just saw an article, I forgot who posted it, but a little girl, they had a bomb threat, it was fake, and she wrote on her arm, "Love you, mom and dad," so that if she were killed, like, she would like, oh my god, I'm gonna cry just talking about it, but that's so sad.
Yep.
Just so that her parents would know that she...
That looks like a baby noodle on the screen. She done talking about the worst.
I know, I'm sorry, but the
And
cat was
It's okay, thank you for that, because I was
But that's absolutely one of the things that we worry about. So stress. So I don't think I would find it to be surprising if we start noticing people a lot earlier having heart attacks than before, especially if it's stress related.
Mars rover story.
What's the next slide?
That one's sad too. The one
Oh.
you're laughing. He sends the signal.
Defined angina.
Well, there's different types of angina.
Well, of course there are. But what's angina? If I just said angina to you, what kind of patient are you seeing in your mind? Chest pain. Is it necessarily cardiac related?
No.
We don't know, right? It can be stress related. It can be GERD. What the hell is GERD? Acid reflux, or otherwise known as heartburn.
Fibrosis.
Oh my God, this is going to take me forever. So yes, when patients come in complaining of angina, we have to try to figure out what's going to make it go away. Always do least invasive to most invasive. That's the first thing is first. We're not going to put someone on nitro right away. We're going to do other drugs in between. What are some things?
Mona, aspirin, oxygen, morphine.
Do you guys still do Mona?
Well, we were taught to do it. But
You were taught to do it, but do you guys still do Mona?
I hope you're not getting Mona in a pediatric
Oh, no.
Yeah, pediatrics you don't use Mona for pediatric chest pains. But here's the thing, even for regular chest pain now, a lot of the EMS systems are getting away from doing morphine. They'll use aspirin for sure. Oxygen you don't even need to do unless your O2 sats are less than what? 90. Go all the way down to 90. Because you can have oxygen toxicity. That is a real thing. So if my O2 sats are fine, do I truly need more oxygen? Probably not. Give me some aspirin. Aspirin's always going to happen. And then after that, start to treat the underlying causes. Who's ever had a GI cocktail?
I gave it.
They're disgusting.
You gave it?
I gave it.
Did it work?
Yes, it worked for him.
Nope.
So if your angina is true chest pain from an MI, a GI cocktail is not going to work. GI cocktail is lidocaine, Melanta, and there is
Can you repeat that M one?
Mylanta.
Isn't it like
It's
like a what's it called?
oh shit.
Talking mushroom.
What's the pink stuff? Isn't that what it's in it? Yeah, Pepto. Is it like a Pepto?
It's actually it's something similar to that, but it's not Pepto because the GI cocktail is white.
Not Imodium. Not Imodium.
The lidocaine is the biggest thing that's in it, and that's just to numb the esophagus and everything. Most times your chest pain is because your esophagus is on fire. If it's true cardiac, nothing's going to get rid of your angina except narcotics and putting you on nitro. The nitro will get rid of your chest pain first. Oh, now I have to log back into ATI. I'm monitoring an exam. Ooh.
We'll show that you don't have angina in your chest pain. Because it could be like
What kind of
because
exam?
if the lidocaine is able to numb that means it will get.
Someone's taking one of the predictors. So now I have to go through all of this. Yes. I should have known. I normally bring my charger with me wherever I go when I'm not.
Is it a Donatel?
What is it?
Donatel?
Yes.
What is it?
Donatel?
Donatello?
Yes.
Donatello
Ninja Turtles.
Versace.
Shima Boo.
It's Versace.
Well, I'm watching that right now.
Okay, she's done.
That,
On Netflix?
yeah.
I love the video where she's like, it's Versace, not Versace.
Donatol is an old GI drug. Let's see if I can pull this back up now without having to
But
go
the
in.
one I gave, it wasn't like a full GI cocktail. There was the lidocaine and the,
Melantha?
yeah.
Insufficient funds to Donatell.
All right.
I did. Shaken, not stirred.
No, he was an alcoholic patient, so.
What is
Oh, prevent the delirium tremor. You get a detox them in a
Alcoholic,
day.
homicidal, and suicidal. It's a great combination.
I was doing well, right?
Okay. All right. When we talk about angina, there are 3 different classifications for it. The one that we worry about the most is unstable. This is somebody who, no matter what they do, their chest pain is always different. So nothing makes it worse, nothing makes it better. It comes and goes. It's unstable. We put those patients on nitro drips. These are the patients that go to the CCU. These are the patients they'll go to a step-down unit if they can take the nitro drip. You have to titrate the nitro. It's more difficult to treat, it's unpredictable, and you don't know what's going to make it worse. So sometimes just being at rest, your chest pain should go down, right? Because you're not working yourself to death. And if it doesn't, we got a problem. So this is the harder one to treat. Some people have chronic angina. What do we give those guys? What do they take when they're at home? Sometimes they're on like clonidine patches to keep themselves open a little bit, keep their blood pressure down. But we also send them home with nitro bottles. So what does nitro look like in?
It's a tiny little pill, but it's in a brown bottle.
Why is it in a brown bottle?
Photosensitive.
It's sensitive to light. So then these poor guys are walking around with their little angina bottles. Where do they normally stuck?
Pocket.
The pocket, where it's nice and warm, right? Well, we don't want to keep it there. It's actually supposed to be cool. Or they keep it in their glove box. Do you know that that's another famous spot for your geriatric patients to put their nitro is in the glove box of their car? Where they should keep it in a cool, dry place, correct? Okay. Stable angina, people know what makes it worse and what makes it go away. So if I'm walking a long distance and I get chest pain every time I walk 500 feet, but I'm good up to 300 feet, and then I rest, and then I can go some more, well, that's stable. I know what can control it and what can't. So usually the pattern is the same. Duration can be the same. Usually your patient's going to your doctor's office. And he gets there and he's got chest pain by the time he gets there. But now that he's sitting down and he's resting, his chest pain goes away. Because he's not exerting himself, right? Okay. Variant angina, seen in patients with migraines. What's going on in a migraine?
Pain.
Compressing the vagus nerve.
Okay, so you have vasospasm, right? That's usually what we're trying to do, is we're trying to calm the vaso nerve down. So yeah, that's why it's seen with history of migraines, is because it's a spasm. So typically, patients who have really severe migraines, some of them will get chest pain. So if you can get the migraine under control, you can control the chest pain. Raynaud's syndrome, what's Raynaud's?
When your fingertips are like blue and white.
They turn white if you're in a flare. Your toes as well. You're cold from the inside, not necessarily the outside. People can touch the outside of your hands and they're like, oh, you feel fine. But you're like, yeah, but it's cold inside. But then the pale white, but it's only the palms and the fingertips. We tell these patients not to go where?
The cold.
Yeah, not in the cold. So not the cold.
Oh, heat, right?
So what's one of the issues they have if you have Renaud's and it's in your hands and you go to the grocery store? You got to stay out of the frozen food section, right? Some people can't even grab a gallon of milk because that's too cold. Toes can get the same thing. It's actually a capillary issue in getting blood supply to the capillaries, because your fingertips they're vascular, but they're vascular because of capillaries, right? Not necessarily veins and arteries down this far.
Don't they get blocked, right?
They can, yes. So sometimes, especially with migraines and sometimes with Raynaud's, we actually put them on beta blockers. Do you know if you really want to control, if people have really bad migraines, the way to control them is actually putting them on beta blockers.
Same with stage fright.
Yep. Raynaud's, you can put them on beta blockers as well. Don't know why it works. We don't care to know why. We just know that it does. Okay?
So, sorry, for that,
Yep.
can they have like, I mean, even if they don't really have a history of that, can they still have the angina? I don't know.
They can.
Okay.
And sometimes, do any of you ever notice that sometimes you have a little bit of chest pain and you're like, oh, it went away?
Yeah.
It's like, how do you know when to go into the ER? How do you know when to get evaluated? Do you know why why women are still die more from MIs than guys do?
Our symptoms are
Because we
different.
don't go. And typically, if we have chest pain, it's not a heart attack. It's usually something else and we ignore it. By the time it gets to be chest pain and it's truly a heart attack, we were having an MI a couple of days prior to that. What are our symptoms?
Jaw pain.
Can be jaw pain, shoulder, back shoulder pain. Most women, though, once they have shoulder pain in the back, what did they think they actually did? Pulled a muscle. We're like, oh, I was mopping the house. It's 2,300 square feet. I was just mopping away because I can't let my kids do it because they don't do it like I can, and I get it cleaner than anybody else, and nobody else can help me do my stuff. Does that sound like someone you know?
Angel. She would say that.
Yeah.
Yep.
Okay. Here's the thing. If you have health problems, you have to watch things like that.
Or shoveling.
Shoveling.
Like over the weekend that they found.
I was like 6 when he died.
Really?
Yeah, when he died shoveling the snow.
Wet snow?
Oh, the last snow we just had, I was so mad. Nick
Did
was
you work there,
working.
man? They found somebody outside.
No.
Oh, the snow sucked.
This last round did suck. Okay. When we talk about angina, look, epigastric, right down here. People always think, oh, no, down a little lower, come down here. Left shoulder down the arms, interscapulary, neck and jaw. If you have epigastric that radiates to the neck and jaw and the arms, sometimes you look like this. This is most guys. Guys that have chest pain, they literally, if they're truly having an MI, they will clench their chest. And they will actually say, God, it feels like someone is sitting on me. Women, we don't say that. So when EMS picks people up, they look for cues like that. Tell me what it feels like. Never put words in the patient's mouth. Do not refer to things. Let them tell you. It's open-ended questions. Can you tell me what your chest pain feels like? Okay, and they say, it just hurts right here. So what's your next question? What kind of pain? Well, it feels kind of dull, just like I feel like I have a lump just sitting there, and if I could just burp, it would go away. Okay? Then what do I want to ask without giving anything away to a patient? You have pain anyplace else? Don't ever ask them, do you have jaw pain? Do you have neck pain? The minute I infer to a patient that they may have pain somewhere, it's going to happen. So that's why it's always open-ended. Have them discuss it with you. So what happened before? It's always what precipitated the chest pain. Okay? Quality of the pain. Scale. 1 to 10. No, 20 does not exist on the pain scale. It never will. Okay? Tell your patient you can't have 20 out of 10 chest pain because 20 doesn't exist. Make them tell you it's 10 out of 10. Radiation. Ask them, does it go anyplace else? Okay? Don't infer anyplace else. Don't ask them specifically. Just say, do you have pain in any other location? Because if it's their great toe, you could care less. But if they say, you know, the middle of my back really hurts, that should heighten you a little bit, right? And then timing. When did it start? How long has this been going on? When someone says my chest pain has been there for a month, do you honestly think you're dealing with a heart attack at that point? No. So things like this matter. And you will actually, ER physicians are really great about asking it just like this. PQRST. These are the things they want to know. Okay? Precipitating factors. Something to keep in mind. Young couples. I have taken care of women who have been in their 30s and 40s who have had MIs. And they've gone into cardiac arrest. And it's usually during intercourse. You need to know this for one very important reason. Because if you manage to save the patient, it's going to be an issue and it's something that's going to have to get discussed once the patient's to the point where they can go home. I had one patient, she was 35, flat out went into SVT, had an MI, and coded right in the middle. Husband called 911, started CPR immediately. Bit of an awkward position to be in, would you agree? What do you do first? It's like, okay, someone's got to get dressed. That better be me. So the fear set in. The one question the husband asked us, he managed to, EMS got her back once they responded. She came into the ER. She was in the ICU. We intubated her for a couple of days, got her stable. And when we were getting ready to, one of the things he kept asking, he goes, will I ever be able, can we have sex again? Or can she never, ever have sex again? Because in his mind,
He did it to her.
he killed her. So he's like, okay, this is what we were doing. Does that mean she can never do this again? That's a conversation as a nurse you best be willing to have, because they're never going to ask the doctor that. Because they don't establish that trust with a physician like they do with the nurse. It took us a long time to just sit down with them and discuss things with him. Because he was afraid. That's his wife. So your factors matter. If you're shoveling wet snow, I'm probably going to tell you, go buy yourself a damn snow blower. Don't shovel anymore. Or go pay the neighborhood kid to shovel the snow for you. $25 is going to be well worth it. Okay? So you need to know. Okay. There's a difference between angina and an MI. Angina, nitro is what's going to relieve the pain. Symptoms usually last for less than 15 minutes. I know it used to be that you needed to know the difference. I would be sure you know the difference. MIs, the pain is actually extended. Your time frame is a lot longer. It can be 30 minutes to an hour. Usually, with angina, you don't have shortness of breath. You don't have diaphoresis or anything like that. Your chest just hurts. If you're having an MI, chances are, first off, you're going to get sick. A lot of guys actually throw up when they're having chest pain and they're having an MI. The body is trying to tell you to do something and do it quickly. So you're going to experience all kinds of things. That's why you have distress, you have anxiety. Over here, I just have chest pain. Okay? Nitro doesn't always relieve an MI. In order to get that cardiac pain to go away in the chest, you actually need the opiates at that point. But now, let's throw something else into the mix. Pericarditis and a PE. All of these cause chest pain. That's why chest pain is such a horrible descriptor coming into the ER. I have chest pain. You bury your head. You're like, well, here's a 3-hour workup. Come in with abdominal pain. You're like, oh. They're like, I need to be out of here in an hour. Oh, well, you're not leaving in an hour. That's usually a 3 to 4 hour workup as well. Tell them ahead of time. Say you're going to be here for about the next 4 hours while we run a bunch of tests, because some of them take a while. PE, you guys should be able to pick out a PE very quickly, because it all has to do with if you have frothy red sputum, shortness of breath. It can be relieved if I sit forward a little bit. My D-dimer is elevated, and my ABG shows that I'm in respiratory acidosis. Chances are I've got a PE going on. Take me down to the damn CT scanner, get me diagnosed, and start me on a heparin drip. I'm good to go. Pericarditis and an MI. Okay? Well, this is, when you look at things back and forth, you're like, well, this just sucks. Okay. I have sharp pain. With pericarditis, it's progressive. An MI, it comes on right away. Pericarditis, what is that? The inflammation of the pericardium, correct? Okay, sits around the heart. Is it going to cause me chest pain? Absolutely. Okay, now I just need to treat it. Chances are, it worsens if I lay flat. So never lay your patients down who have heart infections. Don't lay them down flat. Keep them at least at a 30-degree angle. Because laying down completely flat puts a lot of pressure on the heart. It also puts a lot of pressure on the lungs. That's why your PE patients, they like to sit forward as well. Pericarditis, they have dyspnea, but it's due to painful respirations and the fact that their heart is rubbing against the pericardial area. So if you can take that pressure off them, they won't be in as much pain. An MI, on the other hand, I don't care what you do with them. They're going to look crappy. Here's the other thing. MIs, their skin is ashen. What does ash look like? What color? Gray. Gray. Ugh. Gray. Sometimes when you look at the snow and, it starts to melt, it's no longer pretty because it's no longer white, and all the dirt gets into it. It's got that, you're like, well, you look like charcoal.
That's today.
Yeah, it's today, isn't it? You look like crap. Anyone who has ashen skin looks like crap. Let's just put it that way. Clammy, increased heart rate. You may hear S3 and S4. You still shouldn't, but you may. Lab work is what matters here. Learn the lab work to differentiate an MI and a PE. Why do we do a D-dimer?
That's indicative of a clot somewhere.
It's indicative that something is going on. So when you have a positive D-dimer in the emergency room, all it tells me is, oh crap, now I have to send them to CT. I have to dig further. It's great. We want it to be negative. If it's negative, we know someone doesn't have a clot. That's what it's great at telling us. So if I do a D-dimer on somebody versus doing a CT scan immediately, I can get a D-dimer back fairly quickly. If it's negative, I'm not going to send a patient to CT. Always least invasive first before you go the most invasive. CT scan. What's the issue with sending someone to CT scan all the time? Radiation. I don't want to radiate somebody unless I absolutely have to because I increase their incidence of having cancer. That's not what I want to do. If we let emergency room physicians actually treat patients like they know how to treat versus just saying, I'm just going to do everything so that way I don't miss something. Because what they're afraid of is if they miss something, a patient's going to come back years later and sue them because if you had done a CT scan when I came in complaining about this chest pain, you would have noticed that I had this nodule. Maybe, maybe not. That's what docs are afraid of. ER medicine calls it defensive medicine now. Whereas if you let a true ER physician operate under his assessment skills, we do far less scans than we do now. So, D-dimer, all I want to know, if it's positive, all it tells me is I have to send the patient either to nuclear med or CT. That I want it to be negative. And then ABGs, those are easy to do. They hurt. They're painful. Have someone come stick a needle in your artery. They're not fun. It's a bigger needle, first off.
I'm terrified of needles. They weren't having a good time with me.
Yeah. When I'm looking at pericarditis, it's an infection. So what are my two labs for infection?
C-reactive protein.
C-reactive protein, otherwise known as your CRP, and what else? Sed rate. That's why if you have an elevated CRP and an ESR, I'm going to think of I'm thinking of an infection. Okay, a D-dimer or a PE is not an infection; it's a blockage. An MI is not an infection; it's a blockage. Okay, I want a troponin. I'm going to rule. Quickest way to rule out an MI is to do a troponin. How many times, though, should you do a troponin before you rule someone completely out? At least 3. Why?
Because it could take time for the...
How long? How long before the body... how long after an MI can your troponin be detected in your body?
2 days.
Up to 6 hours. Typically, if you have immediate damage going on, you're going to detect troponin immediately. But it can actually go out 6 hours. So that's why ERs like to at least do 2 sets. Because if I do the first one, in 3 to 4 hours, I should notice some damage. But it can still peak at the 6-hour mark. So they'll do a second set. So if I'm telling you that my chest pain started at 2 o'clock and it's now 4, we're going to do the first set of cardiac enzymes. If my troponin is negative, okay, it's been 2 hours since I complained, they may keep me down in the ER until at least 7 and check it again. If my troponin is still negative at that point, the doctors will usually give your patients one of 2 choices. They will say, you know, your troponin can still bump within the next 6 hours. I can admit you into the hospital, or I can let you go home. They're fairly confident if within the 6-hour mark your troponin hasn't elevated that it's probably not going to. So that's why ER guys, that's why sometimes you keep your cardiac patients down there for 6 hours. Because you want to get those first 2 before you decide to admit. Because I don't know about your places, but I can tell you when we're on high census at St. Cat's or down at Kenosha, the last thing we need to be doing is admitting every chest pain that comes through the door. I don't have beds for them. So the ER scrutinizes it a little bit. So does it make sense now sometimes why your patients sit down there and you're just like, what the hell are we doing with this patient? You have to be able to explain that wait time to your patients. Talk to them about it. Say, hey, look, I know you're anxious to go, but this is what happens with labs, and this is why you're still here. Trust me, a large part of the times if you tell your patient when they're checking into triage, if you just tell them right off the bat, you know, you're going to be here for, 3 to 4 hours. If they really don't need to be there, they'll probably say, oh, you know what, I think I'm going to leave.
It doesn't hurt anymore.
Doesn't hurt anymore. Absolutely. And then sometimes you just never know. So understand this slide and the difference between MI, pericarditis, and a PE. Okay? The only reason a PE causes you chest pain is because where are the damn lungs? Typically, they're going to have more pain back here in the back, especially if they're laying down. So some diagnostic things that we can do. Obviously, I'm sure Dave talked to you guys about your EKGs. Okay? Lab work always. And then you go to stress test for an MI. Stress test. Sometimes we'll keep a patient, put them on a treadmill, let them go, and then we'll discharge them if the chest test was normal. No reason to keep them. If I can't induce the same chest pain, then it's probably not cardiac related. Let them go. Have them follow up with their primary afterwards. Okay. You guys know a lot of these already. Medications for angina. We talk about aspirin. Aspirin is a what, guys? Aspirin and Plavix. Antiplatelets. Plavix and aspirin prevent platelets from sticking together in places you don't want them to. Aspirin truly is not a thinner. It acts, your blood can get a little thin when you're on aspirin, but not to the point where if you get cut or anything like that, we would have to watch for bleeding. That's not usually what happens with aspirin. Beta blockers, that way I can decrease the demand on the heart. Sometimes you may need to, if they're allergic to beta blockers or they can't take a beta blocker, you can do a calcium channel blocker. Obviously, guys, if I'm blocking something, what am I blocking? The name of the... I'm blocking beta, or I'm blocking something from uptaking any calcium. Okay? So just think about what you're trying to block there. ACE inhibitors. What's the number one hallmark sign that someone's allergic to an ACE? Angioedema, dry cough. If they have a dry cough, it's going to lead to angioedema most likely. So that means, what are your ACE inhibitors? The prils, right? So if I'm on lisinopril and I come in with angioedema, are you going to put me on another pril? No. So it can happen weeks after starting a medication. So it's important when you guys start people on blood pressure medications, especially ACE inhibitors, that patient education happens. They should monitor themselves for a couple of weeks. And if they start to notice any swelling, they need to go to the ER and stop the drug immediately. And that becomes an allergy. It's not a side effect. That's an allergy. So then they should be listed as having, they're allergic to ACE inhibitors. Obviously morphine, but a lot of places are getting rid of doing morphine. I know we don't do morphine. We don't do Mona down in the ER at St. Cat's.
We don't do it. We didn't do it at Vista either for a very long time, but they teach you in paramedic for some reason. Not that you do anything anyway.
Yep.
You just transport their chest pain and hope for the
Yep.
best.
Stabilize them, figure out what's going on, do your EKG in the field, and then go. If you're going to do any antithrombics, if we're going to send someone in for cardiac cath, they're always going to get Plavix and aspirin before they go. Beta blockers, any of your meds that end in all, those are your beta blockers. Coumadin, heparin, Lovenox. Those are anticoagulants, but so is Eliquis. What are some of the others? Eliquis, why can't I think of them? Xarelto. Those are all anticoagulants. What's the problem with using Eliquis and Xarelto over Coumadin? No, yeah. We have no way of knowing what your bleeding time is if you take Eliquis or if you take Xarelto. Coumadin, I know what your bleeding time is because it affects that part of the clotting cascade, whereas the others do not. So the reason it's a patient satisfier to go on the other two reasons. One, I don't have to watch what I eat. The vegetables aren't an issue with Coumadin. Second, I don't have to go in for the blood testing. Flip side of that coin. Not going to be in a hurry to take them to the OR, at least for 24 hours if need be, because the likelihood of them being able to bleed out, I don't know what it is, because I don't know what their bleeding time is. An INR cannot tell me what the bleeding time is if you take Xarelto or Eliquis. Only Coumadin. So what are some ways, if my INR is 4 and I need to go to the OR, what are some things that you can do to bring my INR down? Does anyone, can they think of it when you're in the emergency room? You got a trauma patient who needs to go to the OR, but their INR is 3. Transfuse them with what? Plasma. 2 units fresh frozen plasma. Vitamin K. Because we tell patients if you take Coumadin to watch how much vitamin K you intake, because vitamin K reverses Coumadin because of where it affects the clotting cascade. Okay, but Eliquis, Xarelto don't have those issues. When you are talking about acute coronary syndrome, ischemia that is prolonged and not seeming to be reversible, develops into unstable angina, these are patients that have non-STEMIs. They can have STEMIs, but if it's a prolonged thing that's ischemia that's prolonged, they usually don't come in with a STEMI. STEMIs are usually things that happen pretty quickly. Okay? So if I do an EKG and I have fireman's hats or I have tombstones sitting on my EKGs, whoops. We call them fireman hats for a reason. I always love seeing fireman's hat because it does sort of look like the old fireman's hat.
Just a little bit.
Just a little bit. Tombstones, though, oh my God. Those are, I mean, when you see those two on EKGs, you know a patient is truly having an MI. They need to get to the cath lab immediately. Cath lab people, if you work in the cath lab and you're on call, your response time's got to be under 20 minutes because time's of the essence. I know stroke, they're getting ready to change the timing for stroke patients to get into either OR or get into interventional radiology. I think you have to give the TPA. The TPA time now has to be
I thought it was within
the first hour. It used to be within the first 90 minutes. They're changing it, I think, to the first hour, which means your CT has to be back in under 45 minutes.
Which is why they just send them straight from, like, they'll call EMS in the field, or stroke alert in the field, and then.
Goes right through the CT. They don't even go to the emergency room.
Yep, you should just take them directly to CT to get it going. And then you can do your blood work and your EKG afterwards, but get them on the CT table because it takes a while to get those read. Those don't get read. I mean, it just takes time to do the imaging itself. But yeah, they're getting ready to change. So if you're a stroke receiving center or a STEMI receiving center, you have timetables that you have to meet. So I know St. Cat's is a STEMI receiving facility and a stroke. Kenosha is not necessarily certified as a stroke center, but they're getting there. You work at Aurora here in Kenosha? Are you guys a stroke center?
I know we're stroke certified.
So EMS can go into either place. The biggest thing with ACS is if you get plaque buildup, think about it. Eventually it breaks away. Where is it going to travel to? The lungs? Where else from there? The brain. So that's why strokes are such an issue. We need to know why. AFib. Why do we treat AFib?
There's a stroke from it.
You can get a stroke from a clot, right? It goes through the heart, can either block off the heart, or it blocks into the pulmonary, into the little, into your little brachial branches there, or it goes up into the brain and lodges there. Okay. The only reason we go to CT for a stroke is why? See if it's a bleed. It's the only thing I care about. I don't care about anything else for a stroke besides is it a bleed? Because I can't give TPA if it's a bleed. Right? If there's no bleeding there and you're still having a stroke, I can give you TPA as long as you rule in. We've probably talked about this at nauseum by now. Dave's talked to you guys about the signs and symptoms of an MI. Complications. Biggest complication is, in my viewpoint, would be prolonged mitral valve regurgitation, because you probably will need a valve replacement at some point. This is what's going to cause you to stay in AFib. And then eventually you're going to need your mitral valve replaced. It's not good to have regurg. Because if I have blood back up from my ventricle and go back into my atrium and it sits there and that can never get out, it's going to clot just sitting there, correct? So then eventually it breaks loose, it makes its way through, and then it ends up in the brain. You guys always need to be concerned about learning the nursing care. When you guys go to take NCLEX is going to ask you what the nursing care is of these patients. So when you guys ask Dave, what am I supposed to study? And he says everything. What he really wants you also to focus on is the nursing care of the patient. They don't care that you know what the medical diagnosis is. They're assuming you know what the medical diagnosis is when they ask you a question. They want to know if you know as a nurse how to take care of this patient. So I think the biggest thing that we don't necessarily do MONA anymore. Iodine shellfish allergy. Depends on what kind of allergic reaction they have to iodine and shellfish. We may actually just pre-medicate them. I can pre-medicate with Benadryl, Pepsid, and some steroids. I may give you some Solumedrol. And then if you don't have if you get hives from shellfish or iodine, I'm going to give you that cocktail, and then I'm actually going to do the CT scan with contrast. Renal function. This is what I'm concerned about. So any diabetic, because most of your heart patients also have diabetes, correct? Yeah. So any diabetic, if they take metformin, and you've given them any type of contrast medium or dye, they cannot take metformin. You will kill their kidneys. So metformin gets held for 48 hours. To protect the kidneys, you can actually give them Mucomist. That's the stuff that smells like rotten eggs. It's great stuff. But it's a buffer, so it buffs the kidneys from any damage. So it's not uncommon for you to do IV Mucomist. You can actually inhale Mucomist. Sometimes respiratory therapists will use it for people who, especially your ARDS patients, to open up their airway and to get that mucus out. Lessen the mucus, you give them Mucomist. And then of course, last but not least is the famous coronary artery bypass grafting, better known as a cabbage. It's the last thing you want to go for. If it's not going to increase your quality of life, guys, don't do it, right? If you're a bedridden patient and you can't get up, you can't do anything, and you're in your 70s, and it's not going to give you any more quality to have a cabbage, why would you do it? Sometimes you're going to have blockage. That's when you outweigh the risks of a surgery versus the benefits. And your diabetic patients that already have kidney failure, they really need to decide if having a cabbage is worth it. Because you will lose your kidneys and they may not come back, because I have to clamp you sometimes. Depending on what I'm doing and depending on where I'm stripping your veins from, I'm going to clamp blood flow to the rest of your body. All right, we've talked about these drugs, have we not? Yeah. You should be able to figure out how to treat acute coronary syndrome. Beta blockers are huge. Cholesterol-lowering medications, what's the issue with statins? What's one of the side effects of having a statin like Lipitor? What do we tell patients to be mindful of when they're taking Lipitor or any of the statins? leg pain. Statins can actually waste away your muscles. So if they complain of leg pain after you've started them on the medication, it's usually a sign to get rid of it. You got to put them on something else. Usually Crestor is the one you'll usually flip them to. Most insurances will not pay for Crestor first. You have to do Lipitor first. Crestor does not have a generic. It's more expensive. You see? Figuring that out now, right? If there's no generic for a drug, insurances are going to require that you've tried something else before you go to the more expensive ones. But if someone's allergic to Lipitor, the next line of defense for lowering the cholesterol is usually Crestor. Obviously, your most important things nursing diagnosis-wise is always assessment. When they complain they're having pain, assess the pain. Don't blow it off. Your aides cannot come back with a pain assessment for you. Only thing that your nursing assistants can do for you is tell you that the patient is complaining of chest pain. It's up to you to go do the assessment and ask the questions. Now, aides do it all. Patients give aides so much information, and it's great information because what I tell you once, I'm probably going to tell differently the next time someone else comes and asks me. So that's why your history and physical is always a little different from person to person. The doctor got something, but no, you got something else, and you're like the aide, got the whole life story, and they left out that they've had something for 3 days, but the aides spend more time with the patients, so they get into these casual conversations, and the patient gives more information up because it takes them a while to think about what's been going on. So you always have to do the pain assessment. If you're working with an LPN, they do not necessarily assess, guys. They gather your data for you. They can get you numerical information. But it's up to you to go find out what type of chest pain they're having. Please do not rely on someone else's viewpoint. If your aide comes back and says, hey, look, when I was doing vitals on this patient, I noticed his heart rate's, elevated, his blood pressure's elevated, he's complaining of chest pain, but then he started telling me all of this, and this is what it feels like. You at least now have something to go off of, but it's your duty to actually go and physically do that assessment yourself. Address things that alleviate stress and anxiety. If it's nursing school, you just have to graduate, sorry. If it's really bad, some people, they can't handle the stress of being in school. So they may have to take some time off. And that's okay too. Addressing underlying patients' emotional and behavioral reactions. And this is a big one. Understand medication and their side effects. Guys, RNs are the only ones who can do initial teaching. You cannot start someone on a new blood pressure medication and ask the LPN to go do the teaching. Not their function. You have to do the patient teaching. The LPN can then reinforce the teaching. And if they still have questions about drugs, the CNAs really shouldn't be doing any pharm teaching at all. That needs to go back to the nurse level. So then the aides need to be able to turn to you guys and say they still have questions about their blood pressure medication. It's just like when you guys are signing a consent that you witnessed. All you're doing is witnessing their signature. You're not witnessing that they understand what they're signing up for. You're just witnessing that it was Michelle Metzger who signed up to go and have her gallbladder taken out. She signed the form. If I say I still have questions, you just turn around and you let the surgeon know or the OR nurse know patient still has questions. All you're witnessing is their signature, that's it. You're not witnessing understanding. Okay? Stay within your pay grade. Don't take on more than what you get paid for. All right, I'm not necessarily going to, I don't think there's, NCLEX is not really going to get you guys into really answering questions about what is and what happens in procedures. They want to know what you do after the procedure. So if you work in the ICU in an area where you take care of patients that have just had a CABG, then you know they have chest tubes in place, they have swan lines in, they have art lines in for a period of time. All of those tubes eventually come disconnected. They get pulled out as long as the patient is doing well. Chest tubes are usually in for a few days, as long as the blood decreases and you don't have a large output. The cardiovascular surgeon will actually then tell you that you can DC the chest tube. Technically, unless you've been trained to discontinue a chest tube, that is a surgeon function or a doctor function. You can assist. Unless you've been trained, you should not pull them yourself. Art lines, yes, we teach you how to pull an art line all the time. We teach you how to pull central lines, like you get checked off on that. Chest tubes are different. There are some places the cardiovascular surgeons will let nurses do it. In other places, cardiovascular surgeons say absolutely not, I'll do it, but you need to assist. Obviously, pain management, ambulation is huge. Cardiac rehab is after discharge. You don't usually do cardiac rehab in the hospital. Okay? I'm just trying to get you out of bed and ambulating, deep breathing and coughing, using the what? Incentive spirometer. Any patient in the hospital, I don't care if they had surgery or not. Any patient should have an incentive spirometer, especially if they're staying in bed. Your lungs just don't operate. Women need to be more involved in care due to late presentation. It actually takes longer to heal, ladies, sometimes, because we're stubborn mules. Okay? We don't think anything's wrong with us.
True.
It's just the way it is. What's sudden cardiac death?
Abrupt loss of cardiac output and cerebral blood flow.
So these are patients that actually don't have any underlying cardiac disease. These are usually young people. If someone in their 20s and 30s goes down and you have to start CPR, they usually just went into VFib for some reason, but they usually do not have heart disease.
We just had a 14-year-old playing with his siblings happened to this. We couldn't get him back, but it was just randomly playing with his siblings, and then he just dropped dead in front of him.
Most of these patients actually have a prolonged QT interval and they never knew it.
And you don't want to give Zofran to those kids, right? Or something. You want to give something to them.
You have to be careful with mood altering, like Haldol and things like that. Haldol actually lengthens your QT. Your problem with sudden cardiac death is you usually don't know why something happened, but somehow you lost cardiac output and very quickly. Most of the time these patients go into VFib and they drop dead. These are patients who are usually healthy. They're your avid exercisers, joggers, and they just go. These are your kids playing basketball. These are your kids out on the football field. That's sudden cardiac death because there's no rhyme or reason for it. Those that survive, fear reoccurrence. Chances are, if you get these patients back, they're going to end up with an implanted defibrillator cardioverter. I'm going to probably have both. I'm probably going to have one that's a pacemaker in case I need to be paced for some reason, or it's going to be a defibrillator because I'm going to go into VFib and it needs to shock me. The fear is real. I mean, if you guys were healthy, your BMI was perfect, you had no body fat, your heart rate's normally 45 because you run 5 miles a day, and all of a sudden you wake up and you've been in the hospital and your spouse tells you, well, yeah, you were out running and someone came upon you and you had just dropped dead. Okay, you're going to be a little afraid.
Like Zurich High School did a thing where it was everybody signed up and it was part of your gym credit class. They just did EKGs right in the gym and they caught 2 kids with prolonged QT intervals.
This is what happens. It's easy to pick up. It's a matter of doing an EKG on somebody. You can pick up a prolonged QT interval on someone who, if you just do an EKG. We don't do EKGs as part of a sports physical.
Which is such a terrible thing.
Which is something that is so preventable. Anybody can do an EKG. You don't have to be a nurse. EMTs do them. You can have a fire department go and do a round of EKGs on somebody.
Excellent way to get CE.
But see, the high schools are now starting to get smart. They're like, wait a minute. We know that we can catch people. If it's a way to save a life, wouldn't you want to know? Because then you can get it treated. If you have a prolonged QT interval, there's ways to treat that. But we need to know first. It's just like aneurysms in the brain, guys. People who have aneurysms that explode, they never knew they had it. So how were they going to know? If they pick it up by chance, it's because they had a CT scan done for some other reason. And they're like, oh shit, look at this. They picked up an AV malformation because I came in complaining of a headache. I just caught someone before they ended up having an cerebral bleed. We can catch sudden cardiac death, especially in kids. It's more and more frequent. What's the other reason why we've noticed it more and more recently?
Energy drinks and stuff?
Energy drinks. That is exactly why. If you don't know you have a prolonged QT interval and you start drinking a bunch of Monsters and you have some Red Bulls and then you go out and you increase your cardiac demand because you are on the basketball team and your heart rate's up to 150 because you're just running up and down the court and all of a sudden you stop.
So pre-workout could probably do that too.
Oh yeah. I love it. It's delicious.
Think about it. When you see these people, if you've ever been in a basketball game or you've ever been someplace where someone just goes down abruptly, that's exactly what happens. They are in full motion and then all of a sudden they're down on the ground. And they either fall forward or backwards. But that's what sudden cardiac death is all about.
I looked it up. Zofran, you don't give with QT, like prolonged, because it can cause torsades.
Torsades, okay, yep. How do you treat torsades?
Magnesium.
Correct. Usually 2 grams within 10 minutes. Who normally suffers from torsades?
Adult males. Pregnant females. I don't know.
Alcoholics. Why?
They don't drink anything else but alcohol.
Because they get all their nutrients through alcohol. So they don't eat. So their mag is usually low. You treat torsades with magnesium. I've only seen true torsades one time.
It's scary when you put them on the monitor.
But when you see it, you look at it and you're like,
sir, are you okay?
You're like, holy crap, that's torsades. Because it looks like it on the monitor. I've had one patient, I looked at it, I'm like, I took it to someone. I'm like, oh gosh, look at this, I have torsades. And they're like, you sure do. It was textbook. It's textbook. And then we're like, oh, you have an alcoholic. Oh, that's right. And I gave him 2 grams of mag and he came right out of his torsades. His mag level was just low. That's how you deal with it. Okay, heart failure. You guys know the difference between right-sided and left-sided heart failure? Okay. Left-sided heart failure backs up to where? Right-sided heart failure backs up to where? Body, the peripherals, right? That's why you get the edema. If I have left-sided failure and I'm coughing up a storm and I sound like a washing machine's in my throat, it's because of the fact that I'm pulmonary congested, correct? Okay, you got to get the blood to move around. You got to get the left ventricle to pump. Get rid of the resistance against the left ventricle from the peripheral side. Heart failure, guys, this is still something that we can't get a control over. The longer we live, the longer we're going to have cardiac issues. The heart dies. It's a muscle, right? It gets old. It's like, I'm tired of beating in this body. It's not gender specific. Sometimes you have just primary heart failure, or it can be secondary. If it's secondary, anything secondary is usually because it's caused by something else. Diabetes is the biggest issue here. Diabetics. There is a reason why it sucks to be a diabetic. It does so much damage to your body because people, if you don't control your blood sugars, you will destroy the capillaries. You'll destroy your veins. You'll destroy your arteries. It's important to keep control. Eventually, everything shuts down. Okay? We still have too many cases that are diagnosed every year. Hypertension, diabetes, smoking, things that you can control. If you remain relatively healthy, it doesn't mean that you will never have heart disease, because you can still have heart disease, because heart disease can also be genetic, correct? You can look back. We know African Americans have a higher incidence of heart disease and high blood pressure. It is a genetic thing. It is an ethnic thing. We also know that white males also have an increased incidence of having heart disease. You can't change that. You can't change your nationality. I'm sorry. No matter how hard you try, your DNA is your DNA. But if you know in your family that people, a long line of people, have had diabetes and heart disease, and it would behoove you to lead a healthier lifestyle, correct? Doesn't always mean you have to be a vegetarian. Vegetarian diets are not always the best depending on what you've got going on in your hereditary lifestyle. But things to be mindful of. And if you're someone in your family that anyone has ever suffered from sudden cardiac death, trust me, they're going to work you up. They're going to do an EKG a lot sooner on you. Okay? Did Dave talk to you guys about preload and afterload? Think a little bit? Okay. You guys look extremely tired.
I'm not gonna lie, yeah.
I know. It's a lot of information.
Good information.
Let's do this. We'll leave it here. I'll tell Dave that we stopped at preload and afterload.
Perfect.
Okay?
So should we be prepared
We
to have
actually-
a
I
test
appreciate
at the
it.
second half of the day, or?
I don't know. I'll leave it up to him. So look over some of this stuff. If you guys really look at some of your other slides when you talk about most all of you know what dietary restrictions are for cardiac patients. I mean, that's not new information for you guys. There's probably not going to be a whole lot on transplants. Endocarditis. That's old information because I know in adult health too, you sort of talk about endocarditis a little bit and you talk about pericarditis. Some of this is going to be review for you guys. Okay? So I would at least look through the rest of the slides just so that you understand. Cardiac guys, the workup's all the same. I mean, you can only do so many different variations of a cardiac workup. They all look the same. Okay? So I'll let Dave know that that's where we left off because you guys were getting sleepy. And you guys, your valve regurgitation, your stenosis, this is all repeat information for you guys as well. I know it is. You talked about it in adult health too. It's called ages ago, moons ago. It's like the dark ages. Yep. I would just go over the slides. Once you guys look at them, it's going to make sense to you. You're going to be like, oh yeah, cardiac is not that difficult. Respiratory is much more difficult than cardiac.